Today we're talking about Chapter 32, the structure and function of the cardiovascular and lymphatic system. Our pages may not specifically line up, but we'll be reading the entirety of the chapter. So we'll jump right in. The functions of the circulatory system include delivery of oxygen, nutrients, hormones, cells of the immune system, and other substances to body tissues and removal of the waste products of the cellular metabolism. Delivery and removal are achieved by an extensive array of tubing, the blood and lymphatic vessels, connected to a pump, the heart. The heart continuously pumps blood through the blood vessels in collaboration with other systems, particularly the nervous and endocrine systems, which are intrinsic regulators of the heart and blood vessels. Immune system cells, nutrients, and oxygen are supplied by the immune, digestive, and respiratory systems. Gaseous wastes of cellular metabolism are blown off by the lungs, and other wastes are removed by the kidneys and digestive tract. A critical component of the circulatory system is the vascular endothelium, which is considered by some to be a separate endocrine organ. The endothelium is a multifunctional tissue whose health is essential to normal vascular, immune, and hemostatic system function. Endothelial dysfunction is a critical factor in the pathogenesis of vascular and other diseases. The circulatory system. The heart is comprised of two conjoined pumps moving blood through two separate circulatory systems, one to the lungs and one to all the other parts of the body. Structures on the right side of the heart, or right heart, pumps blood through the lungs. This system, termed the pulmonary circulation, is described in Chapter 35. The left side of the heart, or left heart, sends blood throughout the systemic circulation, which supplies all of the body except the lungs. These two systems are serially connected so that the output of one pump becomes the input of the other. So we can take a look at the right pulmonary artery, the right pulmonary vein, the right lung capillaries, and then we have the left pulmonary artery, the left pulmonary vein, and the left lung capillaries. We also see some of the liver circulation, the vena cava, the systemic capillary beds, and then we see the aorta, the hepatic portal vein, system circulation, intestinal capillaries, and renal capillaries. So some of the basic anatomy and physiology. So looking right at it, the right side of the heart, we have blood that enters the right atrium. It goes through that happy right AV valve into the right ventricle, where it goes through the pulmonary SL valve and into the pulmonary artery, where it goes into the lungs. I guess once that blood enters the lungs via the arteries and arterioles, all the way through to the capillaries, where we have that inhale-exhale exchange of blood between the capillaries and the venules. It goes back into our veins via the pulmonary vein into the left atrium. Then that left AV valve, which separates our atrium and the ventricle, to finally the left ventricle, where it gives that final squeeze through the aortic SL valve and delivers that blood into the aorta, into the arteries of each other system of the body, where the arterioles of each organ then carries those oxygenated blood into the capillaries of each organ. The exchange happens, the oxygen gets dropped off, and that deoxygenated blood goes into the venules of each organ, through the veins of each organ, back to the vena cava, where it re-enters that right atrium and goes through that happy circle once more. So again, this is just a very 1, 2, 3 of basic anatomy. So looking at it, arteries carry blood from the heart to all parts of the body, where they branch into arterioles and even smaller vessels until they become a fine meshwork of capillaries. Capillaries allow the closest contact and exchange between the blood and the interstitial space, or interstitium, the environment in which the cells live. Venules and then veins then carry the blood from capillaries back to the heart. Some of the plasma and liquid component of the blood passes through the walls of the capillaries into the interstitial space. This fluid, called lymph, is returned to the cardiovascular system by vessels of the lymphatic system. The lymphatic system is also a critical component of the immune system described in chapters 7 and 8, which you can take a look at. I've read through those, so I may post a link. The heart. The adult heart is about the size of a fist and weighs about 200 to 350 grams. It lies obliquely or diagonally in the mediastinum, the area above the diaphragm and between the lungs. Heart structures can be categorized by function. It looks like we've got 3 major functions here. The first is the structural support of heart tissue and the circulation of pulmonary and systemic blood through the heart. This category includes the heart wall and fibrous skeleton, which enclose and support the heart and divide it into 4 chambers: the valves that direct flow through the chambers, and the great vessels that conduct blood to and from the heart. Function 2 is the maintenance of the heart cells. This category comprises vessels of the coronary circulation, the arteries and veins that serve the metabolic needs of the heart cells, and the heart's lymphatic vessels. And finally, the stimulation and control of the heart action. Among these structures are the nerves and specialized muscle cells that direct the rhythmic contraction and relaxation of the heart muscles, propelling blood through the pulmonary and systemic circulatory system. So, structures that direct circulation through the heart wall. The heart wall itself. The heart wall has 3 layers: the epicardium, the myocardium, and the endocardium, and is enclosed in a double-walled membranous sac called pericardium. The pericardial sac has several functions. It prevents displacement of the heart during gravitational acceleration or deceleration. It also serves as a physical barrier that protects the heart against infection and inflammation from the lungs and pleural space, and contains pain receptors and mechanoreceptors that can cause changes in blood pressure and heart rate. The 2 layers of the pericardium, the parietal and visceral pericardia, are separated by a fluid-containing space called the pericardial cavity. The pericardial fluid, which is about 20 ml, is secreted by the cells of the mesothelial layer of the pericardium and lubricates the membranes that line the pericardial cavity, allowing them to slide smoothly over one another with minimal friction as the heart beats. The amount of character of the pericardial fluid are altered if the pericardium is inflamed, which we'll take a look at in chapter 33. Things like pericarditis that can cause that inflammation, for instance. So, taking a look at just, I guess, a section of the heart, we'll see that there are coronary vessels, fatty connective tissue on the outside of the heart, as well as fibrous pericardium. We also have a pericardial space, and then we have on more of the inside of the heart the serous pericardium, which has the parietal layer, the visceral layer, and the myocardium, all attaching eventually to the endocardium. And then on the very inside of the heart, it looks like they have a trabecula carneae. Say that 3 times fast. The outer layer of the heart, the epicardium, provides a smooth surface that allows the heart to contract and relax within the pericardium with a minimal amount of friction. The thickest layer of the heart wall, the myocardium, is composed of cardiac muscle and is anchored to the heart's fibrous skeleton, the heart muscle cells. Cardiomyocytes provide the contractile force needed to propel blood through the heart and into the pulmonary and systemic circulation. About 0.5% to 1% of cardiomyocytes are replaced annually. Thus, over a lifetime, about one-half of these muscles or muscle cells are replaced. The limited myocyte turnover is insufficient for restoration of contractile function. The capacity to generate cardiomyocytes in the adult human heart has created great interest and investigation for potential cardiomyocyte replacement for persons with cardiac pathologies. So, I guess there is research done on myocardial regeneration. The thickness of the myocardium varies tremendously from one heart chamber to another. Thickness is related to the amount of resistance the muscle must overcome to pump blood from the different chambers. The internal lining of the myocardium is composed of connective tissue and a layer of squamous cells called the endocardium. The endocardial lining of the heart is continuous with the endothelium that lines all the arteries, veins, and capillaries of the body, creating a continuous, closed circulatory system. Chambers of the heart. Well, the heart has four chambers: the right atrium, right ventricle, and left ventricle. These chambers form two pumps in series. The right heart, a low pressure system pumping blood through the lungs, and the left heart, which is a high pressure system pumping blood through the rest of the body. Blood flow through these chambers is illustrated in that figure we took a look at already. The atria are smaller than the ventricle and have a thinner wall. The ventricles have a thicker myocardial layer and make up much of the bulk of the heart. The wall of the right ventricle is about 4 to 5 millimeters thick, and that of the left ventricle, the most muscular chamber, is about 12 to 15 millimeters thick. The ventricles are formed by a continuum of muscle fibers that originate from the fibrous skeleton at the base of the heart, chiefly around the aortic orifice. And actually we have another illustration here of the heart with all of its valves, such as our tricuspid valve, our aortic semilunar valve, and mitral valve. I feel like I'm missing one more valve. When I see it, I'll point it out. Moving on. The wall thickness of each cardiac chamber depends on the amount of pressure or resistance it must overcome to eject blood. The two atria have the thinnest walls because they are low pressure chambers that serve as storage units and conduits for blood that is emptied into the ventricles. Normally, there is little resistance to flow from the atria to the ventricles. The ventricles, on the other hand, must propel blood all the way through the pulmonary and systemic circulation. The ventricular myocardium must be strong enough to pump against pressures in the pulmonary or systemic vessels. The mean pulmonary capillary pressure, the force the right ventricle must overcome, is only about 15 mmHg, whereas the mean arterial pressure, the force the left ventricle must overcome is about 92. Because the pressure is markedly higher in the systemic circulation, the walls of the left ventricle is several times thicker than that of the right ventricle. The right ventricle is shaped like a crescent or a triangle, enabling it to function like a bellows and effectively eject large volumes of blood through the pulmonary semilunar valve into the low-pressure pulmonary system. The left ventricle is larger and bullet-shaped, helping it to eject blood through the larger aortic semilunar valve into the high-pressure systemic circulation. The ventricles are structurally more complex than the atria. Each ventricle contains muscle fibers that divide it roughly into an inflow tract, which receives blood from the atrium, and an outflow tract, which sends blood into the circulation. So, taking a look, we have that inflow. Here's our atrium. We have an inflow tract. And an inflow tract and an outflow tract into our circulation. Or inflow here in our right atrium and into the pulmonary. Okay, so normally blood does not flow between the chambers of the right side of the right side of the heart and the chambers of the left side of the heart, except in a fetus before delivery. The atria are separated by the interatrial septum and the ventricles by the interventricular septum. There is an opening between the right and left atria before birth called the foramen ovale. However, this opening closes shortly after birth in most individuals. We'll discuss that more in chapter 34. The interventricular septum is an extension of the fibrous skeleton of the heart. Indentations of the endocardium form valves that separate the atria from the ventricles, and the ventricles from the aorta and pulmonary arteries. So, our fibrous skeleton of the heart. 4 rings of dense fibrous connective tissues provide a firm anchorage for the attachments of the atrial and ventricular musculature, as well as the valvular tissue. The fibrous rings are adjacent and form a central fibrous supporting structure, collectively termed the annuli fibrosi cordis. The valves of the heart. One-way blood flow through the heart is ensured by the 4 heart valves, as well as the pressure gradients that they maintain. During ventricular relaxation, the 2 atrioventricular valves open and blood flows from the relatively higher pressure in the atria to the lower pressure in the relaxed ventricles. With increasing ventricular pressure, these valves close and prevent backflow into the atria as the ventricles contract. The semilunar valves of the heart open when the intraventricular pressure exceeds aortic and pulmonary pressures, and the blood flows out of the ventricles and into the systemic and pulmonary circulation, respectively. After ventricular contraction and ejection, intraventricular pressure decreases and the pulmonic and aortic semilunar valves close when the pressure of the vessels is greater than the pressure in the ventricles, thus preventing backflow into the right and left ventricle, respectively. This is what prevents the regurgitation in the heart. The atrioventricular, or AV, tricuspid and mitral valve openings are composed of tissue flaps called leaflets, or cusps, that are attached at the upper end to one of the rings in the fibrous skeleton of the heart and at the lower end of the papillary muscles by the chordae tendineae. The papillary muscles are extensions of the myocardium that help hold the cusps together and downward at the onset of ventricular contraction, thus preventing their backward expulsion or prolapse into the atria. The right AV valve is called the tricuspid valve because it has three cusps. The tricuspid opening, or orifice, has the largest diameter of all the heart valves. The left AV valve is a bicuspid, or two cusps, valve called the mitral valve. The tricuspid and mitral valves function as a unit because the atria, fibrous rings, valvular tissue, chordae tendineae, papillary muscles, and ventricular valves are all connected. Collectively, these six structures are known as the mitral and tricuspid complex. Damage to any one of these six components of the complex can significantly alter function and contribute to heart failure. Blood leaves the right ventricle through the pulmonic semilunar valve, and it leaves the left ventricle through the aortic semilunar valve. Both the pulmonic and aortic semilunar valves have three cup-shaped cusps that arise from the fibrous skeleton. The pulmonic cusps are slightly thinner than the aortic cusps. The lower edges of each cusp are suspended from the root of the pulmonary artery and/or aorta, with the upper valve edges freely projecting into the vessel lumen. When the ventricles contract, the cusps behave like one-way swinging doors. The force of the blood propels the cusps outward against the vessel wall. When the ventricles relax, blood fills the cusps and causes the free edges to meet in the middle of the vessel, closing the valve and preventing any backflow. The greater vessels, or great vessels, blood moves in and out of the heart through several large vessels. The right heart receives venous or deoxygenated blood from the systemic circulation through the superior vena cava and the inferior vena cava, which enter via the right atrium. Blood leaves the right ventricle and enters the pulmonary circulation through the pulmonary artery. The pulmonary artery divides into right and left pulmonary arteries to transport deoxygenated blood from the right heart to the right and left lung. The pulmonary arteries branch further into the pulmonary capillary bed, where oxygen enters the blood and carbon dioxide leaves it as each gas moves from its higher to lower concentration gradient. Four pulmonary veins, two from the right lung and two from the left, carry oxygenated blood from the lungs to the left side of the heart. The oxygenated blood moves through the left atrium and ventricle and out into the aorta, which delivers it to the systemic vessels that supply the body. So again, 1, 2, 3 of how the blood moves through the heart to get oxygen when it was deoxygenated. Blood flow during the cardiac cycle. The pumping action of the heart consists of contraction and relaxation of the heart muscle or myocardium. Each ventricular contraction and relaxation that follows it constitute one cardiac cycle. Blood flow through the heart during the single cardiac cycle is illustrated in figure 32.4. During the period of relaxation termed diastole, blood fills the ventricles. The ventricular contraction that follows, termed systole, propels the blood out of the ventricles and into the pulmonary and systemic circulation. Contraction of the left ventricle occurs slightly earlier than contraction of the right ventricle, which is when you listen to the heart, it's that lub-dub. During ventricular systole, blood from the veins of the systemic circulation enters the thin-walled right atrium from the superior and inferior vena cava. Venous blood flow or venous blood from the coronary circulation enters the right atrium through the coronary sinus. The right atrium fills, which, along with the falling right ventricular pressure, allows the right AV, or tricuspid valve, to open and fill the right ventricle during ventricular diastole, occasionally called atrial systole. The same sequence of events occurs a split second earlier in the left heart. The four pulmonary veins, two from the right lung and two from the left lung, carry blood from the pulmonary circulation to the left atrium. As the left atrium fills and the left ventricular pressure falls, the mitral valve opens and blood flows into the left ventricle. Left atrial contraction, termed atrial kick, provides significant increases in the volume of blood entering the left ventricle at the end of diastole. Filling of the right and left ventricles occurs during one period of diastole. 5 phases of the cardiac cycle can be identified in Figure 32.5 and 6. As blood is pushed through the inflow and outflow tracts of the ventricles, it flows around the crista supraventricularis, the muscle that separates the inflow from the outflow tracts, and is mixed by passing through the strands of the trabeculae carnae. Looks like here we have uh, some different diagrams in regards to how the heart contraction occurs. So here we see the atrial systole. It's when those atriums contract and blood flows into the ventricles. Then the beginning of ventricular systole is when the heart or the ventricles contract. Period of rising pressure, right? We're going against that pressure of resistance. Again, only about 15 in the right side and 90 on the left. We hear that heart sound, the lub-dub. The beginning of ventricular diastole is when it starts to relax again. The pressure of falling, period of falling pressure, when things refill. Into the atriums. And the flow begins again. So, then we can talk about normal intracardiac pressures, the pressure within the heart. Normal intracardiac pressures are shown on table 32.1 and 32.7. Your atrial pressure, see venous pulse in figure 32.5, curves are composed of the A wave, which is generated by the atrial contraction, and the V wave, which is an early diastolic peak caused by the filling of the atrium from the peripheral veins. A smaller pressure increase, the C wave, occurs after the A wave in early systole and may represent bulging of the mitral valve into the left atrium during early systole. Two aspects of falling atrial pressure have also been named. The X descent follows the A wave and is produced by the descent of the tricuspid valve ring and by the ejection of blood from both ventricles. The Y descent that follows the V wave reflects the rapid flow of blood from the great veins and right atrium into the right ventricle. Left ventricular pressures are illustrated by a peak systolic pressure and an end diastolic pressure, which is the ventricular pressure immediately before the onset of systole. The minimal left ventricular pressure occurs in early diastole. So we have some intracardial pressures. The right atrium, its normal range is anywhere between 0 and 8. And the right ventricular systolic, which is anywhere between, which the mean is 24, but ranges anywhere between 15 to 28. And its end diastolic is anywhere between 0 to 8, with a mean of 4. The left atrium should be higher in ranges. Again, it has a larger resistance in the body. So the left atrium, again, would be lower, 4 to 12, with a range of 7, or a mean of 7. Whereas the systolic is anywhere between 90 to 140. That is what gives us our systolic blood pressure. So with a mean of 130, and the end diastolic is anywhere between 4 and 12 with a mean of 7. But that is not our diastolic blood pressure. So this is just the pressure in or within the heart. So again, the right side is much lower due to the fact that its only resistance is our pulmonary arteries and veins and your pulmonary circulation. That's all that's preventing this pressure. Whereas on the left side, everything that's being oxygenated, your liver, kidneys, digestive system, your feet, your arms, your brain, everything else is being or is providing the resistance on that left side. So structures that support cardiac metabolism, the coronary vessels. The myocardium and other heart structures are supplied with oxygen and nutrients by the coronary circulation, which is part of the systemic circulation. The coronary arteries originate just beyond the aortic semilunar valve's cusps and receives blood through the opening in the aorta, called the coronary ostiae. The cardiac veins empty into the right atrium through another ostium, the openings of a large vein called the coronary sinus. The regulation of the coronary circulation is described in the later section. This is where you see that the heart is cruel. Most of the oxygenated blood actually goes right back to the heart to keep it pumping. The coronary arteries. The major coronary arteries are the right coronary artery, the RCA, and the left coronary artery, or LCA. They traverse the epicardium, myocardium, and endocardium, and branch to become arterioles and then capillaries. Their main branches are outlined in box 32.1, and because women's hearts weigh proportionately less than men's hearts, coronary arteries are much smaller in women. So that's your piece of trivia today. So there's a box here regarding the main branches of the coronary arteries. The left coronary artery arises from a single ostium behind the left cusp of the aortic semilunar valve. It ranges from a few millimeters to a few centimeters long. It passes between the left atrial appendage and pulmonary artery and generally divides into two branches, the left anterior descending or LAD artery and the circumflex artery. Other branches are distributed diagonally across the free wall of the left ventricle. So again, the left anterior descending and the circumflex are all part of the left coronary artery system, whereas the left anterior, so to the front, and descending, meaning going down, the LAD artery, also known as the anterior interventricular artery, delivers blood to portions of the left and right ventricle and much of the interventricular septum, travels down the anterior surface of the interventricular septum towards the apex of the heart. The circumflex artery travels in a groove, or coronary sulcus, that separates the left atrium from the left ventricle and extends to the left border of the heart. It supplies blood to the left atrium and the lateral wall of the left ventricle. Often branches to the posterior surfaces of the left atrium and left ventricle. And then finally, that right coronary artery originates from an ostium behind the right aortic cusp. It travels from behind the pulmonary artery and extends around the right heart to the heart's posterior surface, where it branches to the atrium and ventricle. Three major branches are the conus. It supplies blood to the upper right ventricle, the right marginal branch, which supplies the right ventricle to the apex, and the posterior descending branch, which lies in the posterior interventricular sulcus and supplies smaller branches to both ventricles. The collateral arteries are connections, or anastomoses, between branches of the same coronary artery, or connections of branches of the right coronary artery with branches of the left. The epicardium contains more collateral vessels than the endocardium. New collateral vessels are formed through two processes: arteriogenesis, or new artery growth, branching from pre-existing arteries, and angiogenesis, growth of new capillaries within a tissue. The collateral growth is stimulated by shear stress, an increased blood flow speed near an area of stenosis or narrowing, and the production of growth factor and cytokines, including monocyte chemoattractant proteins, or MCP-1, and vascular endothelial growth factor, or VEGF. Investigators using a murine model show that the mixed lineage kinases Jun, amino terminal kinases, the MLK-JNK, signaling pathway is required for formation of native collateral arteries that can restore circulation following arterial occlusion. The collateral circulation the collateral circulation assists in supplying blood and oxygen to the myocardium that has become ischemic following stenosis of one or more coronary artery or coronary artery disease, known as CAD. Unfortunately, diabetes, which predisposes to coronary artery disease, also impedes collateral formation. Because of the increased production of anti-angiogenic factors, such as endostatin and angiostatin, current research is focused on identifying whether some factors that stimulate collateral growth might be useful treatment for myocardial ischemia. So, that is why it is much better to have a heart attack or any kind of stenosis when you're older in age versus younger in age, because we can use that lifelong growth factor in our vascular endothelial growth factor and that MCP-1, that monocyte chemoattractive protein 1, to create these, what do they call them here? Our collateral arteries. Whereas when you are young and have a heart attack, you don't have the time and your body didn't have the chance to create those collateral circulation to assist. Coronary capillaries. The heart has an extensive capillary network. Blood travels from the arteries to the arterioles and then into the capillaries, where exchange of oxygen and other nutrients take place. Alterations of the cardiac muscles dramatically affect blood flow in the capillaries. For example, in the ventricular hypertrophy, or the enlargement of the ventricular myocardium, the capillary network does not expand along with the muscle size or muscle fiber size. Therefore, the same number of capillaries must now perfuse a larger area. This results in decreased exchange of oxygen and nutrients. At rest, the heart extracts 70% to 80% of the oxygen delivered to it, and the coronary blood flow is directly correlated with myocardial oxygen consumption. Investigators are studying the microcirculation, the capillaries and arterioles, and not just the main coronary arteries in congestive heart failure. That's why the heart is cruel. It is greedy. It takes most of the oxygenated blood in all reality. But that's okay. That's what keeps us alive. The coronary veins and the lymphatic vessels. After passing through the extensive capillary network, blood from the coronary arteries drains into the cardiac veins, which travel alongside the arteries. Most of the venous drainage of the heart occurs through veins in the visceral pericardium. The veins that then feed into the great cardiac vein and coronary sinus on the posterior surface of the heart. Between the atria and the ventricles in the coronary sulcus, the myocardium has an extensive system of lymphatic capillaries and collecting vessels within the layers of the myocardium, and also in the valves. Impairment of cardiac lymphatic function has been hypothesized to impact cardiac conduction, protection from infection, and the development of myocardial fibrosis and atherosclerosis, or plaque buildup. So, structures that control heart action. People's lives depend on the continuous repetition of the cardiac cycle, that's systole and diastole, that occur because of the transmission of the electrical impulses termed cardiac action potentials through the myocardium, as described in chapters 1 and 3, as an electrical impulse passes from cell to cell or fiber to fiber. In the myocardium, it stimulates an intracellular process that results in fiber shortening, that is, muscular contraction or systole. Between action potentials, the fibers relax and return to their resting length, causing diastole. The muscles or the muscle fibers of the myocardium are electrically coupled so that action potentials pass from cell to cell very rapidly and efficiently. The myocardial structures that allow the action potentials to move so rapidly through the heart are the gap junctions and the intercalated discs. In the intercalated discs, the channel-forming proteins called connexins form pores in the gap junctions. Bless you. As a result of these structures, plus the heart's conduction system, an action potential generated in one part of the myocardium passes very quickly through the heart, causing rapid, organized, sequential contraction of the atria and then the ventricles. The myocardium contains its own pacemakers and conduction system. Bless you. Specialized cells that enable it to generate and transmit action potentials without input from the nervous system. The pacemaker cells are concentrated at two sites in the myocardium called nodes. The sinoatrial, or SA node, and the atrioventricular, AV node. Although the heart is innervated by the autonomic nervous system, or sympathetic and parasympathetic fibers, Neural impulses are not needed to maintain the cardiac cycle. Thus, the heart will beat in the absence of any nervous connection. One of the many factors that allow heart transplantation to be successful. The cardiac cycle is stimulated by the nodes of specialized cells and then adjusted to the physical need of the body by the autonomic fibers. The sympathetic and parasympathetic nerves affect the speed of the cardiac cycle, your heart rate or beats per minute, the force of contraction, and the diameter of the coronary vessels. The sympathetic nervous system increases heart rate and conduction through the nodes. The parasympathetic nervous system slows heart rate and prolongs intranodal conduction time, and both systems cause coronary vasodilation. So what's new? More understanding on the heart-brain axis. I guess there is a little info. And here it looks like it's talking about your SA node and AV node, your AV bundle of His, your interatrial bundle, subendocardial fibers or Purkinje fibers, your right and left branches of the AV bundle, again the bundles of His, your septum, and your lateral ventricular wall. So how does this all work in terms of your SA node, your pacemaker? It shoots via the interatrial bundle and fibers into the left and right atrium. Your internodal bundle and fibers, your atrioventricular or AV node, then shoot out its own signal to give you your left and right beat. The cardiovascular control centers in the brain, your hypothalamus, your medullary centers, your symp and vagal responses, and your receptors afferents. So the autonomic innervations of cardiovascular system activation inhibit your sympathetic. Sure. So the more understanding of the heart-brain axis. Some of the effects of cardiovascular disease on the nervous system have been known for a long time. However, effects of neurologic disorders on the cardiovascular system are now expanding. Many pathologies of the nervous system can lead to several alterations in function and structure of the cardiovascular system, including changes in your electrocardiogram or ECG or EKG, myocardial injury, cardiomyopathies, and cardiac death. The effects of neurologic injury on cardiac function and structure include electrocardiographic alterations, both benign and fatal after brain injury, and cardiac conduction disturbances from central nervous systems or your CNS injury because of released enzymes can alter automaticity, refractoriness, and repolarization. Neurologic injury and psychological stressors from Chapter 11 can affect cardiac structure by rapid, within minutes, development of subendocardial infarctions, calcifications, and myofibrillar degeneration or myocytolysis. Your paroxysmal sympathetic hyperactivity can develop in pathologies of the autonomic nervous system, such as your ischemia, inflammation, and trauma. The problems associated with paroxysmal sympathetic hyperactivity include aneurysmal subarachnoid hemorrhages, post-cardiac arrest, cerebral ischemia, severe traumatic brain injury, and less frequent brain tumors. The prevalence of neuropsychiatric disorders include SAH, or that's subarachnoid hemorrhage, your TBI, or traumatic brain injury, stroke, seizure, depression, and intense emotions, such as a loss of a loved one, is related to stress-induced cardiomyopathy, especially in postmenopausal women. Emotional stressors are linked to sudden cardiac death, such as anger, fear, grief, and natural disasters. Neurologic injury can result in SCD by inducing fatal dysrhythmias, massive myocytolysis, and myocardial infarction. These changes are hypothesized as a result of catecholamines. More data are emerging related to the interaction between the nervous and cardiovascular systems, and dysfunction in one system may lead to changes in function in the other. Heart action is also influenced by substances delivered to the myocardium in coronary blood. Nutrients and oxygen are needed for cellular survival and normal function, and hormones and biochemical substances, including medications, can affect the strength and duration of myocardial contraction and the degree and duration of myocardial relaxation. Normal or appropriate function depends on the availability of these substances, which is why coronary artery disease can seriously disrupt heart function. Then it comes down to our conduction system. Electrical impulses normally arise in the sinoatrial or SA node, the usual pacemaker of the heart. The SA node is located at the junction of the right atrium and superior vena cava, just above the tricuspid valve. The SA node sits only about 1 millimeter beneath the visceral pericardium, making it vulnerable to injury and disease, especially pericardial inflammation. The SA node is nourished by the sinus node artery, which passes through the center of the node. The SA node is heavily innervated by both sympathetic and parasympathetic nerve fibers. In the resting adult, the SA node generates about 60 to 100 action potentials per minute, depending on the age and physical condition. Each action potential travels rapidly from cell to cell and through the atrial myocardium, onward to the atrioventricular node or AV node, as well as causing both atria to contract and begin systole. The AV node, located in the right atrial wall superior to the tricuspid valve and anterior to the ostium of the coronary sinus, conducts the action potential onward to the ventricle. It is innervated by nerves from the autonomic parasympathetic ganglia that serves as receptors for the vagus nerve and cause slowing of impulse conduction through the AV node. From the AV node, conducting fibers converge to form the bundle of His, or atrioventricular bundle, within the posterior border of the interventricular septum. The bundle of His then gives rise to the right and left bundle branches. The right bundle branch, or RBB, is thin and travels without much branching to the right ventricular apex. The thinness and relative lack of branches of the RBB make it susceptible to interruption of impulse conduction by damage to the endocardium. The left bundle branch, or LBB, in some hearts divides into two branches, or fascicles. The left anterior bundle branch passes the left anterior papillary muscle and the base of the left ventricle and crosses the aortic outflow tract. The left anterior bundle branch is susceptible to damage from the aortic valve, or the left ventricle. The left posterior bundle branch, or LPBB, travels posteriorly, crossing the left ventricular inflow tract to the base of the left posterior papillary muscle. This branch spreads diffusely through the posterior inferior left ventricular wall. Because of relative non-turbulent blood flow through this portion of the left ventricle, the LBB is somewhat protected from injury caused by wear and tear. Terminal branches of the RBB and LBB are the Purkinje fibers. They extend from the ventricular apexes to the fibrous rings and penetrate the heart wall to the outer myocardium. Portions of the interventricular septum of the ventricles are the first areas to be excited. Both the RBB and LBB activate the septum. The rapid spread of the impulse to the ventricular apexes is accomplished from the extensive network of Purkinje fibers. Last to be activated are the basal and posterior portions of the ventricles. Cardiac excitation. From the SA node, the impulses that begins systole spreads through the right atrium at the conduction velocity of about 35 centimeters per second. Because impulses from the SA node arrive at the AV node very quickly, investigators have proposed that these nodes are connected by internodal pathways, called the anterior, middle, and posterior internodal pathways. However, the existence of these pathways is controversial, and not all experts agree that they even exist. So, there you have it. The action potential is delayed in the region of the AV node, possibly because of electrophysiologic differences in the cells that compromise the AV region. Conduction velocity within the node is about 10 centimeters per second, markedly slower than the conduction through the atria. The delay between atrial and ventricular excitation permits an additional boost to ventricular filling by atrial contraction, that atrial kick. From the AV node, the impulse travels from the AV bundle and through the bundle's branches to the Purkinje fibers. Conduction velocities in the AV and Purkinje fibers are the most rapid in the heart. Ventricular activation occurs sequentially in 3 phases: your septal activation, your apical activation, and your basal, your upper and posterior activation. The first areas of the ventricles to be excited are portions of the interventricular septum. The septum is activated from both the RBB and the LBB. Although the impulses travels from the left to the right, the extensive network of Purkinje fibers promotes the rapid spread of the impulses to the ventricular apexes. Activation traverses the heart wall from the inside outward, from the endocardium to the epicardium. The basal and posterior portions of the ventricles are the last to be activated. Deactivation, which begins in diastole, occurs in the opposite direction, spreading from the outside inward, or from your epicardium to the endocardium. All areas of the ventricle recover at about the same rate. So that leaves us with the propagation of cardiac action potentials. Electrical activation of the muscle cells, termed depolarization, is caused by the movement of ions, including sodium, potassium, calcium, and chloride, across cardiac cell membranes. Deactivation, called repolarization, occurs that same way. Movement of ions across cell membranes was described in Chapter 1, and the electrical activation of muscle cells will be described in Chapter 44. Movement of ions into and out of the cell creates an electrical voltage. The difference between the cell membrane, called the membrane potential, the resting membrane potential, and myocardial cells is between 80 to 90 millivolts, whereas that of the SA node is anywhere between 50 to 60 millivolts. And that of the AV node is between 60 and 70 millivolts. During depolarization, the inside of the cell becomes less negatively charged as positive ions move inside. In cardiac cells, the difference between resting membrane potential and the decreased negative charge caused by the depolarization of the cardiac action potential. Table 32.2 summarizes that intracellular and extracellular ionic concentration of cardiac muscle. The various phases of cardiac action potential are related to changes in the permeability of the cell membrane to sodium, potassium chloride, and calcium. Threshold is the point at which the cell membrane's selective permeability to these ions is temporarily disrupted, leading to depolarization. If the resting membrane potential becomes more negative as a result of a decrease in extracellular potassium concentration, such as hypokalemia, it is termed hyperpolarization. Normal myocardial cell depolarization and repolarization occur in 5 phases, numbered 0 through 4. Phase 0 consists of depolarization. This phase lasts 1 to 2 milliseconds and represents rapid sodium entry into the cell. Phase 1 is early repolarization, in which calcium slowly enters the cell. Phase 2, also called the plateau, is a continuation of repolarization with slow entry of calcium and sodium into the cell. Potassium is moved out of the cell during phase 3 with a return to resting membrane potential in phase 4. The time between potentials corresponds to diastole. The phases of depolarization and repolarization occur somewhat differently in the SA and AV node cells, a difference that enables these cells to generate cardiac action potentials independently. The cells of the Purkinje fibers, atria, ventricles, begin with a negative resting membrane potential and proceed to a rapid upstroke or depolarization, phase 0, a rapid early repolarization, phase 1, a plateau in phase 2, and rapid later repolarization in phase 3. The fast inward current of phase 0 is mediated by sodium ions flowing through fast channels in the cell membrane and causes the rapid upstroke of the action potential in Purkinje fibers, atria, and ventricles. In contrast, the cells of the SA and AV nodes begin with a less negatively resting membrane potential, proceeds to a slow upstroke in phase 0, and usually lack a plateau in phase 2. The slow inward current mediated by calcium through transient and long-lasting channels and sodium ions flowing through slow channels of the cell membrane is responsible for the action potential of the SA node and AV node. Hence, drugs that block calcium have profound effects on the slow inward current and can alter heart rate. Slow channel blocking drugs such as verapamil are used to treat a variety of cardiovascular disorders. A refractory period during which no new cardiac action potential can be initiated by a stimulus follows depolarization. This effective or absolute refractory period corresponds to the time needed for the reopening of channels that permit sodium and calcium influx. Phase 0 through half of phase 3, a relative refractory period, occurs near the end of repolarization, following the effective refractory period. During this time, the membrane can be depolarized again, but only by a greater than normal stimulus. Abnormal refractory periods as a result of disease can cause abnormal heart rhythms or dysrhythmias, including ventricular fibrillation and cardiac arrest. Normal electrocardiogram. The genesis of normal electrocardiogram is from electrical activity recorded by skin electrodes, that is, the sum of all cardiac action potentials. The P wave represents atrial depolarization. The PR interval is the measure of time from the onset of the atrial activation to the onset of ventricular activation. It normally ranges from 0.12 to 0.2 seconds. The PR interval represents the time necessary to travel from the sinus node through the atrium, the AV node, and his Purkinje system to activate ventricular myocardial cells. The QRS complex represents the sum of all ventricular muscle cell depolarization. The configuration and amplitude of the QRS complex vary considerably among individuals. The duration normally between 0.06 and 0.10 seconds. During the ST interval, the entire ventricular myocardium is depolarized. The QT interval is sometimes called the electrical systole of the ventricles. It only lasts about 0.4 seconds, but it also varies inversely with the heart rate. That's how we can measure definitely if there is a blockage in the heart. Your first degree heart blocks are always that prolonged PR interval. So we do have a couple fun words here. The automaticity, or the property of generating spontaneous depolarization to threshold, enables the SA and AV nodes to generate cardiac action potentials without any stimulus. Cells capable of spontaneous depolarization are called automatic cells. The automatic cells of the cardiac conductive system can stimulate the heart to beat even when the heart is transplanted and, thus, has no innervation. Spontaneous depolarization is possible in automatic cells because the membrane potential does not rest during that phase 4. Instead, it slowly creeps towards threshold during the diastolic phase of the cardiac cycle. Because threshold is approached during diastole, phase 4 in automatic cells is called a diastolic depolarization. The electrical impulse normally begins in the SA node because its cells depolarize more rapidly than other automatic cells. Rhythmicity is the regular generation of an action potential by the heart's conduction system. The SA node sets the pace because normally it has the fastest rate of depolarization. The SA node depolarizes spontaneously 60 to 100 times per minute. If the SA node is damaged, the AV node can become the heart's pacemaker at a rate of between 40 to 60 spontaneous depolarizations per minute. Eventually, however, conduction cells in the atria usually take over from the AV node. Purkinje fibers also are capable of spontaneous depolarization, but at a slower rate. Therefore, the Purkinje fibers only function as pacemakers when the SA and AV nodes are diseased, or there is interruption to movement of electrical current through the heart. Cardiac innervation. Although the heart's nodes and conduction system generate cardiac action potential independently, the autonomic nervous system influences the rate of impulse generation, or the firing, depolarization and repolarization of the myocardium, and the strength of atrial and ventricular contraction. Autonomic neural transmission produces changes in the heart and circulatory system faster than metabolic or humoral agents. Speed is important, for example, in stimulating the heart to increase its pumping action during times of stress and fear, the fight or flight response, or with increased physical activity. Although increased delivery of oxygen, glucose, hormones, and other blood-borne factors sustain increased cardiac activity, the rapid initiation of increased activity depends on the sympathetic and parasympathetic fibers of the autonomic nervous system. The autonomic nervous system is described and illustrated in Chapter 15. Parasympathetic and sympathetic nerves. I said that backwards. These sympathetic and parasympathetic nerve fibers innervate all parts of the atria and ventricles and the SA and AV nodes. In general, a sympathetic stimulation increases electrical conductivity, and the strength of myocardial contraction and vagal parasympathetic nerve activity does the opposite, slowing the conduction of action potentials through the heart and reducing the strength of contraction. Therefore, the sympathetic and parasympathetic nerves affect the speed of the cardiac cycle, your heart rate, and beats per minute. The sympathetic nerves also influence the diameter of the coronary vessels and overall myocardial performance. Stimulation of the SA node by the sympathetic nervous system rapidly increases heart rate. In addition, neurally released norepinephrine or circulating catecholamines interact with beta-adrenergic receptors of the cardiac cell membranes. The final effect is an increased influx of calcium, which increases the contractile strength of the heart and increases the speed of electrical impulses through the heart muscle and the nodes. Finally, increased sympathetic discharge dilates the coronary vessels by causing the release of vasodilating metabolites, resulting from increased myocardial contraction. Efferent sympathetic fibers originate in the thoracic spinal cord and branch into the superior, middle, and inferior cardiac nerves. They join at the cardiac plexus, a neural junction located at the root of the aorta, in front of the trachea. The efferent parasympathetic fibers originate in the medulla oblongata and travel by way of the vagal nerve to join the sympathetic nerves in the cardiac plexus. Parasympathetic vagal activity causes the release of acetylcholine. Receptors for these neurotransmitters are found in the myocardium and coronary vessels of the heart. Acetylcholine decreases heart rate, slows conduction through the AV node, and reduces myocardial contraction strength. The adrenergic receptor function, the sympathetic neural stimulation of the myocardium and coronary vessels, depend on the presence of G protein-coupled adrenergic receptors, which bind specifically with neurotransmitters of the sympathetic nervous system. Receptors physiology is discussed in Chapter 1. The effects of sympathetic stimulation depend on whether 1. The alpha or beta adrenergic receptors are most plentiful on cells of the effector tissue. The neurotransmitter is norepinephrine or epinephrine, and 3. The extent to which the individual's variation in receptor structure caused by single nucleotide polymorphisms, or SNPs, influence receptor responsiveness. There are 5 types of adrenergic receptors, the beta 1, 2, 3, and alpha 1 and 2. Each of the alpha adrenergic receptors also has 3 subtypes, so some sources indicate that there are 9 types of adrenergic receptors. Overall, cardiovascular structures have more beta than alpha receptors. Therefore, effects mediated by the beta receptors predominate. Norepinephrine is released by postsynaptic sympathetic nerve endings in the heart, whereas epinephrine is mainly released by the adrenal medulla and reaches the heart through the bloodstream. The beta receptors are found mostly in the heart, specifically the conduction system, your AV and SA nodes, Purkinje fibers, and the atrial and ventricular myocardium. The beta 2 receptors are found in the heart and also on vascular smooth muscle. Stimulation of both the beta 1 and beta 2 receptors result in an increase in heart rate, your chronotropy, and force of myocardial contraction, inotropy. In addition, stimulation of the beta 2 receptors result in vasodilation because of the location of the receptors on vascular smooth muscle. Overall, beta 1 and beta 2 stimulation enables the heart to pump more blood, and beta 2 stimulation also increases coronary blood flow. And beta 3 receptors are also found in the myocardium and coronary vessels. In the heart, stimulation of these receptors opposes the effects of beta 1 and beta 2 receptor stimulation and decreases myocardial contractility, the negative inotropic effect. Thus, beta 3 receptors may provide a safety mechanism to prevent overstimulation of the heart by the sympathetic nervous system. Norepinephrine binding with alpha receptors, all of which are postsynaptic in the system and coronary arteries, causes smooth muscle contraction and thus vasoconstriction. One of the three subtypes are alpha 2 receptors, and alpha 2A is located on the sympathetic ganglia and nerve terminals. The effects of norepinephrine on these receptors is to inhibit release of more norepinephrine, which promotes vasodilation, thus providing another safety mechanism to prevent excess blood pressure elevation. Dysfunction of alpha and beta adrenergic receptors can occur in many conditions, including diabetes and hypertension, and has been implicated in the pathogenesis of many cardiac diseases, including heart failure, myocardial ischemia, and dysrhythmias. Not a bad overview of how your adrenergic receptors influence the heart. Your myocardial cells, or cardiomyocytes, are composed of long, narrow fibers that contain bundles of longitudinally arranged myofibrils, a nucleus, mitochondria, an internal membrane system, such as the sarcoplasmic reticulum, cytoplasm or sarcoplasm, and a plasma membrane, the sarcolemma, which encloses the cell. Cardiac and skeletal muscle cells also have an external membrane system made up of transverse tubules or T-tubules formed by inward pouching of the sarcolemma. The sarcoplasmic reticulum forms a network of channels that surrounds the muscle fibers. Myofibrils in both cardiac and skeletal fibers consist of alternating light and dark bands of proteins, causing the fibers to appear striped and striated. The dark and light bands of the myofibrils create repeating longitudinal units called sarcomers, which are between 1.6 and 2.2 something units long. The length of these sarcomers determines the limits of myocardial stretch at the end of diastole, and subsequently the force of contraction during systole. Alterations in sarcomere size occur in both physiologic and pathologic myocardial hypertrophy. So here we can take a look at a sarcomere. It's actin-thin filaments, your sarcomere, your myosin-thick filaments, your M-line or M proteins, your elastic filament, and Z-disc. You also see an H-band, an A-band, and an I-band. Your F-actin strands, your troponin, which is that fun cardiac enzyme release, your active sites, and your tropomyosin, your G-actin molecules, your thin myofilament, which I guess shows our myosin head, our myosin, some more myosin head, the shaft, thick myofilament, myosin head, myosin molecule. Sure, I'm not sure really what we're looking at. Your thick myofilament, your myosin molecule, and your myosin microfilament. Oh, I see. That does make a bit more sense. There are differences between skeletal and cardiac muscle, which reflect cardiac function. Your skeletal muscle cells tend to be arranged in parallel units throughout the length of the muscle, whereas cardiac cells are arranged in branching networks throughout the myocardium. Skeletal muscle cells have many nuclei, but cardiac fibers have only one nucleus. Other differences enable cardiac fibers to accomplish the following. three things. Transmit action potential quickly from cell to cell. The electrical impulses are transmitted rapidly from cardiac fiber to cardiac fiber. Because the network of fibers connected at intercalated discs, which are thickened portions of the sarcolemma, the intercalated discs contain three junctions: your desmosomes, or macular adherents, your fascia adherents, which mechanically attach to one cell to another, and the gap junctions, or tight junctions, which allow the electrical impulses to spread from cell to cell throughout a low resistance pathway. Changes in the function of these junctional elements may cause an increased risk for dysrhythmias. They also maintain a high level of energy synthesis. Unlike your skeletal muscle, the heart cannot rest and is in constant need of energy, which is supplied by molecules such as adenosine triphosphate, or ATP. Therefore, the cytoplasm surrounding the bundles of myofibrils in each cardiomyocyte contain a large number of mitochondria, about 25 to 33% of the cell volume. Cardiac muscle cells have more mitochondria than skeletal muscle cells to provide the necessary respiratory enzymes for aerobic metabolism and supply quantities of ATP sufficient for constant action of the myocardium. And then its third action is to gain access to more ions, particularly sodium and potassium, in the extracellular environment. Cardiac fibers contain more T-tubules than skeletal muscle fibers. This increased closeness to the T-tubules gives each myofibril in the myocardium faster access to molecules needed for the transmission of action potential, a process that involves transport of sodium and potassium through the walls of the T-tubules. Because the T-tubule system is continuous with the extracellular space and the interstitial fluid, it facilitates the rapid transmission of the electrical impulses from the surface of the sarcolemma to the myofibrils inside the fiber. This rapid transmission activates all of the myofibrils of one fiber simultaneously. The sarcoplasmic reticulum is located around the myofibrils. As an action potential is transmitted through the T-tubules, it induces a sarcoplasmic reticulum to release its stored calcium, thus activating a contractile proteins, actin and myosin. So here we're taking a look at intercalated discs. We have a dyad, the T-tubule and the sarcoplasmic reticulum. It also shows us our sarcomere, the nucleus, the mitochondria, and myofibrils. And lastly, that's sarcolemma. So, looking at actin, myosin, troponin or tropomyosin complex, and titin. I'm going to call it titin, even though it says titin, maybe? It's now a titin. Within each myocardial sarcomere, thick filaments of myosin constitute the central dark band called the anisotropic band, or A band. The myosin molecule resembles a golf club with two large bulbous heads protruding from one end of a straight shaft. The bilobed heads contain an actin binding site and a site of ATPase activity. A thick filament called myosin microfilament is composed of about 200 myosin molecules bundled together with outward-facing molecules, heads called cross bridges. Because with activation of concentration, they will form force-generating bridges with exposed actin molecules. Actin molecules are part of the thin filaments, the light bands called isotropic bands, or I bands, of the sarcomere containing only actin molecules and no myosin. The thin filaments of actin extend from the Z-line, a dense fibrous line that crosses the center of each I band. The area from one dark Z line to the next Z line defines one sarcomere. In the center of a sarcomere is the H zone, a somewhat less dense region. A thin dark M line travels the center of the H zone. A single tropomyosin molecule, a relaxing protein, lies alongside 7 actin molecules. Troponin, another relaxing protein associated with tropomyosin molecule, forming the troponin-tropomyosin complex. The troponin complex itself has 3 components. Troponin T aids in binding of the troponin complex to actin and tropomyosin. Troponin I, which inhibits the ATPase of actomyosin, and troponin C, containing binding sites for the calcium ions involved in contraction. Troponin T and I molecules are released into the bloodstream during myocardial injury. They are measured to evaluate if the myocardial infarction or other damage has occurred. Once troponin and tropomyosin cover the myosin binding site on the actin, the cross bridges release calcium and myocardium relaxes. A giant elastic sarcomere protein, the titin or connectin, which attaches the myosin to the Z line, acts as a spring and influences myocardial stiffness. Titin structure affects myocardial diastolic filling and has been found to play a role in heart failure. And that is why we measure our troponin levels during any kind of cardiac stress where we are concerned of any kind of heart attack. And now it also explains why we're checking that troponin T and I molecule. One, because troponin I inhibits that ATPase of acetomyosin, and troponin T, which is the binding of the troponin complex to actin and tropomyosin. So what is our myocardial metabolism? Cardiomyocytes depend on the constant production of ATP, which is synthesized within the mitochondria mainly from glucose, fatty acids, and lactate. If the myocardium is underperfused because of a coronary artery disease, anaerobic metabolism must be used as a source of energy. Well, check that chapter 1. Energy produced by metabolic processes sustains muscle contraction and relaxation, electrical excitation, membrane transport, and synthesis of large molecules. Normally, the amount of ATP produced supplies sufficient energy to pump blood systemically. Cardiac work often is expressed as myocardial oxygen consumption, or MVO2, which is correlated with the total cardiac requirements. Your myocardial oxygen consumption, or MVO2, is determined by 3 factors: the amount of wall stress during systole, estimated by measuring the systolic blood pressure; 2, the duration of systolic wall tension, measured indirectly by the heart rate; and 3, the contractile state of the myocardium, which is not measured clinically. So, the coronary artery delivers oxygen to the myocardium. From 70 to 75% of this oxygen is used immediately by cardiac muscle, leaving little oxygen in reserve. Therefore, increased energy needs must be met only by increasing coronary blood flow. Your MVO2 can increase with exercise and decrease with hypotension and hypothermia. As myocardial metabolism and consumption of oxygen increases, the concentration of local vasoactive metabolic factors increases. Some of these, such as adenosine, nitric oxide, and prostaglandins, dilate coronary arterioles, thus increasing coronary blood flow. So, during a myocardial heart attack, that's why we offer nitrates as part of the monosystem to increase that oxygen delivery to the heart, because it does require that 70 to 75% of oxygen. And if it does not, that's why we get, heart cell breakdown. And heart cells that die do not come back. So it all makes sense. Myocardial contraction and relaxation. The myocardial contractility is a change in developed tension at a given resting fiber length, which is simply the ability of the heart muscle to shorten. At the molecular level, thin filaments of actin slide over thick filaments of myosin, called the cross-bridge cycle of the muscle contraction. Anatomically, contraction occurs when the sarcomere shortens, causing adjacent Z lines to move closer together. The width of the A band, which contains the thick myosin filaments, is unchanged, whereas the I band becomes narrower as the overlap between the thick and thin filaments increases. The degree of shortening of the muscle fibers depends on how much the thin filaments overlap the thick filaments. Maximal contraction occurs when the sarcomere length is 2.2 millimeters. At 2.2 millimeters, the number of cross-bridge attachments between the actin and myosin is maximal. So here we are looking at the cross-bridge theory of muscle contraction, where each myosin cross-bridge in the thick filament moves into the resting position after an adenosine triphosphate molecule binds and transfers its energy. So we're looking at this ATP. Let's take a look at the calcium ion release from the sarcoplasmic reticulum binds to the troponin in the thin filament, allowing tropomyosin to shift from its position, blocking the active sites of actin molecule. Okay, and then in part C, each myosin cross-bridge then binds to an active site on the thin filament, replacing the remnants of the ATP hydrolysis, the adenosine diphosphate ADP, and inorganic phosphate PI. Okay. And then part T, the release of stored energy from step A provides the force needed for each cross bridge to move back to its original position. Pulling actin along with it, each cross bridge will remain bound to actin until another ATP molecule binds to it and pulls it back into its resting position of part A. So what it didn't explain nicely is in picture 1 that ATP that moved it forward so that it can grab onto something is pushed back. And it really doesn't show it nicely even in the picture. But I guess that's what pulls it along. So, looking at that cross-bridge cycle some more, or in closer detail, the globular head end of the myosin contains a binding site for actin and a separate enzymatic site that catalyzes the breakdown of ATP to adenosine diphosphate, or ADP, and inorganic phosphate P, which is that figure I think we just looked at. Let's verify. It is. This reaction releases the chemical energy stored in ATP. Magnesium is required for the binding of ATP to the myosin site. The splitting of ATP occurs on the myosin molecule before it attaches to actin, but the ADP and the inorganic phosphate released remains bound to the active site on myosin. The chemical energy released is transferred to myosin, producing a high-energy form of myosin, M. So we have our myosin that attaches to ADP, or ATP, I'm sorry, and then it turns into ADP plus an additional P. The binding of this high-energy myosin-actin form to a cross-bridge releases an energy stored of myosin, ADP and P, producing the force necessary for movement of the cross-bridge. With the attachment of actin to myosin at the cross-bridge, the myosin head molecule undergoes a position change, exerting traction on the rest of the myosin bridge, causing the thin filament to slide past the thick filament. During the contraction, the cross-bridge undergoes several cycles of attachment, movement, and dissociation from the thin filament. Okay, so calcium and the excitation-contraction coupling. Excitation-contraction coupling is the process by which an action potential arriving at the plasma membrane of the muscle fibers triggers the cycle, leading to cross-bridge activity and contraction. Activation of the cycle depends on the availability of calcium, and the amount of force developed is regulated by how much the concentration of calcium ion increases within the cardiomyocytes. Calcium is stored in the tubule system of the sarcoplasmic reticulum. It enters the myocardial cells from the interstitial fluid after electrical excitation, which increases the membrane permeability to calcium. Two types of calcium channels, the L-type and the T-type, are identified in cardiac tissues. The L-type, or long-lasting channels, are the predominant type of calcium channels and are the channels blocked by calcium channel blocking drugs such as verapamil, nifedipine, diltiazem. The major effect of these medications is to decrease the strength of cardiac contraction. The type or transient channels are much less abundant in the heart and are not blocked by currently available calcium channel blocking drugs and are being investigated. Calcium entering the cell from the interstitial fluid triggers release of calcium from the storage sites within the sarcomere. Calcium from these sites diffuse towards the myofibrils, where it binds with troponin. So myocardial relaxation. Relaxation is as vital to optimal cardiac function as contraction, and calcium, troponin, tropomyosin also facilitate relaxation. After contraction, free calcium ions are actively pumped out of the cell back into the interstitial fluid or taken up again by the sarcoplasmic reticulum and stored. As the concentration of calcium within the sarcomere subsequently falls, troponin releases its bound calcium. The tropomyosin complex blocks the active sites on the actin molecule, preventing cross bridges with the myosin heads. Impairment of myocardial relaxation can lead to increased diastolic filling pressures and eventually heart failure. So factors affecting our cardiac output. Cardiac capability can be evaluated by measuring the cardiac output. Cardiac output is calculated by multiplying the heart rate in beats per minute by stroke volume in liters per minute, or per beat. So the normal adult cardiac output at rest is about 5 liters per minute. At rest, the heart rate is about 70 beats, within a normal stroke volume of about 70 ml. With each heartbeat, the ventricles eject much of their blood volume. The amount of ejection per beat is called the ejection fraction. The ejection fraction is calculated by dividing the stroke volume by the end of diastolic volume. The end diastolic volume, or EDV, of the normal ventricle is about 70 to 80 ml per minute squared. And the normal ejection fraction of the resting heart rate measured with gated myocardial perfusion imaging was 66% with an increase or decrease of about 8%. For women, and 58% or plus 8 or plus or minus percent for men. The ejection fraction is increased by factors that increases contractility, for example, a sympathetic nervous system activity. A decrease in ejection fraction may indicate ventricular failure. The effects of aging on cardiovascular function are summarized in Table 32.2. So I think today's studies say that an ejection fraction of 60 to 65% is considered normal, but it can be as high as 65 to 70%. And I believe it is the same for men and women. These numbers are, I think, a little older because this book is from 2018. So please keep that in mind. And the hospital setting will say 65% or greater is a normal heart EF or ejection fraction. But it also comes down to your hospital facility and what it would like us to, go by. So your cardiac index during the resting cardiac performance is unchanged or slightly decreased in women only, whereas the exercise cardiac performance declines because of the decrease in heart rate and stroke volume. Your heart rate during resting cardiac performance slightly decrease, as the exercise cardiac performance increases less than in younger people, possibly because of the decreased cardiovascular response to catecholamines, an overall slight decrease. Your stroke volume at resting cardiac performance has a slight increase, and the exercise cardiac performance also has a slight increase. Your ejection fraction during the resting period stays unchanged but has a slight increase during cardiac performance. It increases less from rest to exercise in older people than in younger people. Your afterload during a resting performance increases, whereas an exercise cardiac performance remains uncertain. Your end diastolic volume remains unchanged at rest, whereas with exercise also stays at unchanged. Your end systolic volume stays unchanged during rest, whereas with exercise, it is higher in the older people than in younger people. Your contraction at rest is increased because of the prolonged relaxation, whereas with exercise it is decreased with vigorous exercise. Your cardiac dilation has no change at rest, but has an increase with exercise at end diastole and end systole. Your O2 max is unchanged or not applicable at rest, but it declines because of a decline in skeletal muscle mass and increase in body fat. 4 factors affect cardiac output directly: your preload, your afterload, your myocardial contractility, and your heart rate. Your preload is the volume inside the ventricle at the end of diastole, ventricular and diastolic volume, and pressure. Your preload is determined by 2 factors: the amount of venous blood returning to the ventricle during diastole and the amount of blood left in the ventricle after systole. Your blood volume and flow through the venous system and the atrioventricular valves determine venous return. The strength of ventricular contraction and the resistance to ventricular emptying determine end systolic volume. Clinically, preload is estimated by measuring the central venous pressure, or CVP, for the right side of the heart and the pulmonary artery wedge pressure for the left side. Normal values of these two estimate from 1 to 5 and 4 to 12 respectively. Heart failure can occur because of an increase in preload, which causes a decline in stroke volume and also an increase in your VEDP, which is the ventricular end diastolic pressure. Increased ventricular end diastolic pressure causes pressures to increase or back up into the pulmonary and systemic venous circulation, increasing plasma outflow through the vessel walls, causing pulmonary edema. And we'll see that in chapter 36. Your left ventricular afterload is the resistance to ejection of blood from the left ventricle. More simply, it is the load the muscle must move during contraction. An index of afterload is aortic systolic pressure. To understand the role of these factors in cardiac performance, it is first necessary to understand two physical laws that explain the mechanism of heart action: the Frank-Starling law of the heart and the Laplace law. So we'll jump right into the Frank-Starling law of the heart. Cardiac muscle, like other muscle, increases its strength of contraction when it is stretched. This relationship was described in 1914 by British physiologist Ernest Starling and was based on the earlier work of a German physiologist Otto Frank. The Frank-Starling law of the heart, or the length-tension relationship of cardiac muscle, relates resting sarcomere length, expressed as the volume of the blood in the heart at the end of diastole, or end diastolic volume, to tension generation, described as development of left ventricular pressure. Thus, the volume of blood in the heart at the end of diastolic or diastole is directly related to the force of contraction during the next systole. Although the change in pressure is related to the volume of the ventricle and consequently to the length of the ventricular muscle fibers, preload is commonly used as an index of ventricular volume. The length tension mechanism is the main mechanism by which the normal right and left ventricles maintain equal minute outputs, even though their stroke outputs may vary considerably during normal respiration. For example, changes in volume occur when an individual assumes a reclining position after being in a standing position. The volume of blood returning to the heart temporarily increases. The right ventricle stretches to accommodate this increase in volume and thereby increases its force of contraction. A larger stroke volume is pumped to the lungs, generating higher pressures. Pulmonary vascular pressure increases, causing a rise in the left ventricular filling pressure, or preload. Left ventricular volume and pressure increases. The left ventricle pumps at a larger stroke volume, and arterial vascular pressure rises. The mechanical function of the heart is characterized by a number of length tension curves. Factors that increase contractility, such as the sympathetic nerve stimulation, cause the heart to operate on a higher length tension curve. A higher tension or increase in ventricular stroke volume is generated without a necessary change in left ventricular end diastolic volume, or your LVEDV, left ventricular end diastolic volume, or fiber length. Heart failure is characterized by a lower length tension curve. The Frank-Starling law of the heart may not apply to dilated or failing hearts because the fibers are already stretched beyond their optimal length. The failing heart responds to increased filling or stretch with a progressive decline in the force of contraction. Thus, at the same left ventricular end diastolic volume as curves A and B, the force of contraction or stroke volume is decreased. So really, it sounds like this only fits in like your healthy individuals. The cross-bridge arrangement with the sarcomere partially accounts for the length tension mechanism of cardiac muscle. According to the Frank-Starling law, the longer the initial resting length of the cardiac muscle fibers, that again optimal length is 0.22 to 0.24 mm, the greater the strength of contraction. At 0.22, an optimal number of active cross bridges exists between the actin and the myosin. However, if the fibers are stretched beyond 2.2 to 2.4 mm, the force of contraction decreases because actin and myosin become partially disengaged, disrupting many of the cross bridges. Excessive stretching to about 3.65 mm causes actin and myosin to become completely disengaged, so that tension, the force of contraction, drops to zero. The relationship between stretch and contraction can be compared with that of a rubber band, up to a certain point, and the more the rubber band is stretched, the farther it will fly when one end is released. Beyond that point, however, the rubber band will break, but, of course, the myocardium does not actually break. So it's a partial comparison. Then the Laplace law. Laplace's law states that wall tension is related directly to the product of intraventricular pressure and internal radius, and inversely related to the wall thickness, as shown in the Laplace's equation. So where T equals the wall tension, and P the intraventricular pressure, times the R internal radius of the sphere, and whatever that symbol is, QM, equals the wall thickness. So we have our wall tension, which equals our intraventricular pressure times the internal radius of the sphere divided by the wall thickness. In other words, the amount of tension generated in the ventricular wall or any chamber or vessel to produce a given intraventricular pressure depends on the size, the radius, and wall thickness of the ventricle. Laplace's law is useful for understanding aneurysm formation, distensibility in blood vessels, and the effects of ventricular dilation on myocardial contraction. Dilation is an important factor in heart failure. When a dilated ventricle, myocardial fibers in the wall must develop greater tension to produce a given pressure within the ventricle. The disadvantage of a dilation is that it increases force or tension in the myocardial fibers required to develop a given pressure inside a dilated ventricle, decreases the rate of fiber shortening, thereby decreasing the ability of the ventricle to eject blood. That leaves us with an afterload. Afterload. Ventricular afterload is the resistance to ejection of blood from the ventricle. Low aortic pressures, or decreased afterload, enables the heart to contract more rapidly, whereas high aortic pressure, increased afterload, slow contraction and cause higher workloads against which the heart must function to eject blood. Pressure in the ventricle must exceed aortic pressure before blood can be pumped out during systole. Increased aortic pressure is usually the result of increased systemic vascular resistance, or SVR, also called total peripheral resistance, or TPR. In individuals with hypertension, increased TPR means that afterload is chronically elevated, resulting in increased ventricular workload and hypertrophy of the myocardium. In some individuals, changes in afterload are the result of aortic valvular disease. That's why we will sometimes see cardiomyopathies in patients who have a high blood pressure. It all makes sense. Myocardial contractility, your stroke volume or the volume of blood ejected per beat during systole, depends on the force of contraction. The myocardial contractility, or the degree of myocardial fiber shortening, Three major factors determine the force of contraction. Changes in the stretching of the ventricular myocardium caused by changes in the VEDV or preload. These changes were discussed earlier, and an excessive increase in preload leads to decreased stroke volume. Your alterations in inotropic stimuli of the ventricles. An inotropic agent affects contractility, and it includes hormones, neurotransmitters, or medications. The sympathetic nervous system neurotransmitters, your epinephrine and norepinephrine, are the most important endogenous positive inotropic agents. The most important negative inotropic agent is acetylcholine, released from the vagus nerve. Many medications have positive or negative inotropic properties that can have significant effects on cardiac function. Cytokines released during sepsis, such as tumor necrosing factor alpha and interleukin 1 beta, are known to impair myocardial contractility. Emerging is the understanding of mitochondrial dysfunction in sepsis and impaired myocardial function, which explains why when we have a septic patient, they become hypotensive due to the fact that they are no longer getting that positive inotropic agent epinephrine and norepinephrine from our neurotransmitters from the sympathetic nervous system. It also means that our cytokines aren't released during sepsis, which means our tumor necrosis factor alpha and interleukin 1b don't work properly. So interesting how that correlates with the heart. The last part is our adequacy of myocardial oxygen supply. Both oxygen and carbon dioxide level tensions in the coronary blood influence contractility. With oxygen saturation less than 50%, which is severe hypoxemia, myocardial contractility is decreased. Circulating catecholamines can increase contractility with moderate degrees of hypoxemia. Again, the heart is cruel. It wants 70 to 75% of that oxygen. So if we're not oxygenating it properly, we are not giving it the chance to beat properly. So we have a preload, afterload, and contractility that all interact with one another to determine stroke volume and cardiac output. Changes in any one of these factors can result in deleterious effects on the others, which result in heart failures. Our heart rate.
Here's what I found.
The SA node activity is the primary determinant of the heart rate. The control of heart rate includes activity on the CNS, autonomic nervous system, neural reflexes, atrial receptors, hormones, your catecholamines, norepinephrine and epinephrine, your thyroid hormones, and growth hormones. Although these are principal factors, heart rate varies naturally with respiration, exercise, neuropsychologic factors such as stress and depression, cardiovascular disease, alcohol and drug consumption, air pollution, meditation, and other factors. This variability in the heart rate is called heart rate variability, or HRV, which we can take a look at figure E, reveals psychologic, environmental, and psychologic elements linked with HRV. I'm sorry, physiologic and psychologic. In addition to HRV, related to the nervous system and hormonal factors of other factors include cardiovascular disease, depression, and pro-inflammatory cytokines, which can lead to an immune dysfunction and inflammation. Neurologic diseases linked with HRV decrease include Parkinsonian syndrome, spinocerebellar degeneration, the Shy-Drager syndrome, multiple sclerosis, and Guillain-Barré. Temperature affects HRV. Temperature decreases can induce bradycardia, and temperature increases can cause tachycardia. I'm not sure why they say an increased heart rate. The proper word is tachycardia. Estrogen levels correlated with HRV. Measures in healthy women and androgen have a parasympathetic effect. High HPV with high testosterone levels. Occupational settings can influence HRV, such as particulate matter, chemicals, electromagnetic fields, vibrating tools, psychosocial environment, working time, fatigue, and other. A chronic exposure to these factors was linked to a decrease in HRV. A high level of work stress was also associated with a low HRV. Heart rate varies naturally with respiration. The rate increases with inspiration and decreases with expiration. This normal alteration in rhythm pattern, called sinus arrhythmia, is caused by changes that occur within the chest cavity because of respiration. Inspiration results in stretch and an associated increase in firing of the SA node that increases heart rate. The stretch is reduced with expiration, and the SA node firing rate slows, resulting in a decrease in heart rate. The average heart rate in healthy adults is about 70 beats per minute. The average heart rate is typically greater in children. Heart rate diminishes by 10 to 20 beats per minute during the sleep and can accelerate to more than 100 beats per minute during muscular activity or emotional excitement. Well-conditioned athletes, the resting heart rate is about 50 to 60 beats per minute. In highly trained or elite athletes, the resting heart rate can be less than 50 beats per minute. These athletes have a greater stroke volume and lower peripheral resistance in active muscles than they had before training. Cardiovascular control centers in the brain. So, the cardiovascular vasomotor control center is the medulla and the pons of the brainstem, with additional areas of the hypothalamus, the cerebral cortex, and the thalamus. The hypothalamic center regulates cardiovascular response to changes in temperature. The cerebral cortex centers adjust cardiac reaction to a variety of emotional states, and the medullary control center regulates heart rate and blood pressure. The nerve fibers from the cardiovascular control center synapse with the autonomic neurons that control the rate of fire of the SA node. As discussed earlier, sympathetic or adrenergic stimulation increases heart rate. When the parasympathetic nerves of the heart rate are stimulated, the primary vagus nerve, the heart slows, and the sympathetic nerves to the heart, arterioles, and veins are inhibited. The resting heart rate in healthy individuals is primarily under the control of the parasympathetic stimulation. While the individual is at rest, parasympathetic effects from the vagus nerve override sympathetic effects in the sinus or in the SA node. Interruption of the vagus nerve causes significant tachycardia, abnormal fast heart rate, because the inhibitory parasympathetic influence is lost. So, our neural reflexes. Our baroreceptor reflex is important in blood pressure control and is mediated by stretch receptors. Your baroreceptors or pressoreceptors in the aortic arch and carotid arteries. Because the receptors respond to mechanical factors, they are also called aortic and carotid mechanoreceptors. When blood pressure falls, the baroreceptor reflex accelerates heart rate, increases myocardial contractility, and causes contraction in arterioles in the systemic circulation. These responses raise blood pressure back toward normal and are critical to maintaining adequate tissue perfusion. Aging is associated with a dysfunction of the baroreceptic reflex and can result in postural hypotension, also known as orthostatic hypotension. The baroreflex also can reduce high blood pressure. The mechanoreceptor
increases their rate of discharge when stretched by blood pressure elevations. Neural impulses are then transmitted over the glossopharyngeal nerve, or the ninth cranial nerve, from the carotid artery, and through the vagus nerve, from the aorta to the cardiovascular control centers in the medulla. These centers initiate an increase in parasympathetic activity and a decrease in sympathetic activity, causing blood vessels to dilate and heart rate to decrease. Responses to the baroreceptor reflex return the blood pressure to its previous level, which may or may not have been normal. Your atrial receptors, your mechanoreceptors that influence heart rate, exist in both atria. They are located where the veins, the vena cava, or the vena cava, the pulmonary veins enter their respective atria. The Bainbridge reflex is the name of the changes in the heart rate that occur after intravenous infusions of blood or other fluids. The changes in heart rate is thought to be caused by a reflex mediated by these atrial volume receptors that are innervated by the vagus nerve. Volume receptors are thought to respond to increased plasma volume. Although this reflex can be elicited in humans, its relevance is uncertain at this time. Stimulation of these atrial receptors also increase urine volume, presumably because of the neurally mediated reduction in antidiuretic hormone. Peptides of the atrial natriuretic family also are released from atrial tissue in response to the increase in blood volume. These peptides have diuretic and natriuretic salt excretion properties, resulting in decreased blood volume and pressure. The atrial natriuretic peptides can relax vascular smooth muscle and oppose myocardial hypertrophy, leading to measurement of blood levels to evaluate clinical status and raising interest in their use as therapeutic agents. Hormones and biochemicals. Hormones and biochemicals affect the arteries, arterioles, venules, capillaries, and contractility of the myocardium. Norepinephrine increases heart rate, enhances myocardial contractility, and constricts blood vessels. Epinephrine dilates vessels of the liver and skeletal muscle and causes an increase in myocardial contractility. Some adrenocortical hormones, such as hydrocortisone, potentiate the effects of the catecholamines. Thyroid hormone, specifically triiodothyronine, causes increases in both heart rate and contractility, resulting in an increase in cardiac output. It also decreases systemic vascular resistance. Your triiodothyronine acts directly on the cardiac myocytes to cause gene transcription and cellular changes that result in more calcium release from the sarcoplasmic reticulum. Awareness of these changes helps to understand the cardiovascular changes that occur with thyroid disease. Growth hormone working together with insulin-like growth factor 1 or IGF-1 also has been shown to increase myocardial contractility. Decreases in levels of growth hormone or thyroid hormone may result in bradycardia, reduced cardiac output, and low blood pressure. Your systemic circulation. The arteries and veins of the systemic circulation are illustrated in 32.19. Your oxygenated blood from the left side of the heart flows through the aorta and into the systemic arteries. These arteries branch into small arterioles that branch into the smallest vessels, the capillaries, where nutrient exchange between the blood and tissue occurs. Blood from the capillaries then enter tiny venules that join to form the larger veins, which return venous blood to the right heart. Peripheral vascular system is the term used to describe the part of the systemic circulation that supplies the skin and the extremities, particularly the legs and feet. So here we're looking at a series of arteries in the human body. We're not going to go over every single one because that's what an anatomy class is there for. And here we are looking at all of our body's veins. Again, we're not going to go through each and every single one of these. This is what anatomy and physiology is there for. I understand this is advanced pathophysiology, so this should be already covered by other lectures. So, looking at the structure of blood vessels. Blood vessels or blood vessel walls are composed of three layers. The tunica intima, the innermost or intimal layer, the tunica media, middle or medial layer, and the tunica externa or adventitia, that's the outermost or external layer, which also contains nerves and lymphatic vessels. These layers are illustrated in 3220. Blood vessel walls vary in thickness depending on the thickness or absence of one or more of these three layers. Cells of the larger vessels are nourished by the vasa vasorum, small vessels located in the tunica externa, and innervated by perivascular nerves. The vasa vasorum arises from the blood vessels itself or from the vessels nearby. So here we're looking at the internal, the medial, and the external, both in large veins and arteries, and then as well as in a medium-sized vein or muscular artery, and then also in the arterial or venule or capillary where they interchange. So adults are capable of growing new blood vessels through three processes, all of which are important in wound healing, but also contribute to tumor growth. The three processes are angiogenesis, arteriogenesis, and vasculogenesis. Both angiogenesis and arteriogenesis occur by growth of new vessels that branch from existing vessels. Angiogenesis is branching of small vessels, such as capillaries, whereas arteriogenesis occurs by branching from larger vessels, such as arterioles. Vasculogenesis is a term that refers to the growth of vessels from progenitor or stem-like cells that originate in the bone marrow and other body tissues. So looking at the arterial vessel. Arterial walls are composed of elastic connective tissue, fibrous connective tissue, and smooth muscle. There are two types of arteries, elastic and muscular. The elastic arteries have a very thick tunica media that contains more elastic fibers than smooth muscle fibers. Elastic arteries include the aorta and its major branches, and the pulmonary trunk. Elasticity enables the vessel to absorb energy imparted to the blood by ventricular contraction, and they stretch as blood is ejected from the heart during systole. During diastole, elasticity promotes recoil of the arteries, which is important for the maintaining blood pressure within the vessel. The retransfers the energy from the elastic arterial walls to the blood, whereas the muscular arteries are medium and small size arteries, farther from the heart than the elastic arteries. They contain fewer elastic fibers and more muscle fibers than the elastic arteries. Of their function is to distribute blood to arterioles throughout the body. Because their smooth muscle can be stimulated to contract or relax, they can play a role in controlling blood flow and in directing flow to the parts of the body with the highest need at the time. During exercise, more blood is sent to the skeletal muscles, while after a meal, more blood is directed to the gut and liver. Contraction narrows the vessels, the lumen, which diminishes flow through the vessel. This condition is termed vasoconstriction. When the smooth muscle layer relaxes, more blood flows through the vessel lumen, a state called vasodilation. An artery becomes an arteriole at the point where the diameter of its lumen narrows to less than 0.5 mm. The arterioles are composed almost exclusively of smooth muscle with elastic or with little elastic tissue. Arterioles regulate the flow of blood into the capillaries by vasoconstriction, which retards the flow of blood into the capillaries, and vasodilation, which permits blood to enter the capillaries freely. The thick, smooth muscle layer of the arterioles is a major determinant of the resistance blood encounters as it flows through the systemic circulation. The capillary network is composed of connective channels called metarterioles and true capillaries. Your metarterioles have discontinuous smooth muscle cells in the tunica media, whereas capillaries lack any smooth muscle cells. The capillaries branch from the metarterioles, meeting at a ring of smooth muscle called the precapillary sphincter. As the sphincters contract and relax, they regulate blood flow through the capillaries. Appropriately stimulated, the precapillary sphincter helps maintain arterial pressure and regulate selective flow to vascular beds. Capillaries are composed solely of a large endothelial cell, surrounded by a basement membrane. Their thin walls and unique structure make possible the rapid exchange of water, small, low molecular weight soluble molecules, some larger molecules, such as albumin, and cells of the innate and adaptive immune system between the blood and interstitial fluid. Based on their structure, three types of capillaries have been described: continuous, sinusoid, and fenestrated. In the renal glomerulus, for example, the endothelial cell walls contain oval windows or pores, termed fenestrations, which are covered by a thin diaphragm. Sinusoid capillaries are found in the liver and bone marrow. Substances pass between the capillary lumen and the interstitial fluid in several ways: through junctions between endothelial cells, through fenestrations in endothelial cells, in vesicles moved by active transport across the endothelial cell membrane, or by diffusion through the endothelial cell membrane. A single capillary may be only 0.5 to 1 millimeter in length and 0.0 millimeter in diameter, but the capillaries are so numerous that their total surface area may be more than 600 meters squared. So our endothelium, the vascular endothelium or blood vessel lining, is important to several body functions and is considered by some to be a separate endocrine organ. All tissue depends on the blood supply, and the blood supply depends on endothelial cells, which form the lining, or endothelium, of the blood vessels. In addition to substance transport, the vascular endothelium has important roles in coagulation, antithrombogenesis, and fibrinolysis. The immune system function, the tissue growth and wound healing, and vasomotion, the contraction and relaxation of vessels. The endothelium performs these vital functions through synthesis and release of vasoactive chemicals. Because of its varying role, the actual structure of the endothelium may vary in different vascular beds. For example, within the lymph nodes and the endothelial cells of specialized venules, called high endothelial venules, are uniquely structured to support the movement of lymphocytes from the blood into the lymph node. Endothelial injury and dysfunction are central processes in many of the most common and serious cardiovascular disorders, including your hypertension and atherosclerosis. So again, we see our vasa vasorum, the nerve, your tunica adventitia, or the outermost section. Then we have our tunica media, the middle section, and the tunica intima, the innermost section, which show our basement membrane and endothelium. And here we're looking at C. The endothelium supports numerous functions through synthesis and release of vasoactive fibers. So we have our cytoplasm, the plasma, the interstitial fluid, water-filled pores. Our plasma membranes are oxygen and carbon dioxide, are sodium, potassium, amino acids, glucose, and exchange of proteins. All sorts of good stuff. So there's some functions of the endothelium, your filtration and permeability, your vasomotion, your hemostasis balance, your immune or inflammation, and your angiogenesis, your vessel growth. And lastly, lipid metabolism. Veins, on the other hand, the smallest venules downstream from the capillaries, have an endothelial lining surrounded by fibrous tissue. The largest venules, those farthest from the capillaries, are surrounded by a few smooth muscle fibers comprising a thin tunica media, so that middle section is very thin. Compared with arteries, veins are thin-walled and fibrous with a large diameter. A given vein is larger than the artery that lies within the same sheath. Veins are more numerous than arteries. In veins, the tunica externa has less elasticity tissue than that in arteries, so veins do not recoil after distension as quickly as arteries. Like arteries, veins receive nourishment from the tiny vasa vasorum. Some veins, typically in the legs, contain valves that regulate the one-way flow of blood toward the heart. These valves are folds of the tunica intima and are structurally similar to the semilunar valves of the heart. Backflow in veins of the legs is stopped as the flaps of the valves fill with blood and block the vessel. The position of the valves also facilitates blood flow in the proper direction during venous compression. When a person stands up, contraction of the skeletal muscles of the legs compresses the deep veins of the legs and assists the flow of blood toward the heart. This important mechanism of venous return is called the muscle pump. So here you have a relaxed muscle and then a contracted muscle, and because of that pump or high pressure, blood flows up. And that's how that blood comes back from our legs to the heart. So factors affecting blood flow. Blood flow, the amount of fluid moved per unit of time, is usually expressed as liters or milliliters per minute. So either L per minute or ml per minute. The most important factors that influence blood flow are pressure and resistance, followed by velocity, turbulent versus laminar flow, and compliance. So your pressure resistance. Pressure in a liquid system is the force exerted on the liquid per unit area and is expressed clinically as millimeters of mercury, or torr. 1 torr is the same as 1 millimeter of mercury. Blood flow to a specific organ depends partly on the pressure difference between the arterial and venous vessels supplying that organ. Fluid moves from the arterial side of the capillaries, a region of greater pressure, to the venous side, a region of lesser pressure. Resistance is the opposition of blood flow. Most opposition to blood flow results from the diameter and length of the blood vessel. Changes in blood flow through an organ result from changes in the vascular resistance within the organ. Because of the increase or decrease in vessel diameter at the opening or closing of vascular channels, resistance in a vessel is inversely related to blood flow. That is, increased resistance leads to decreased blood flow. Poiseuille's law indicates that resistance is directly related to tube length and fluid viscosity, or blood viscosity, and inversely related to the radius of the tube to the fourth power. Blood flow is inversely related to the resistance, so that the greater the resistance in the vascular bed or tissue, the lower the blood flow. Resistance to flow cannot be measured directly, but it can be calculated if the pressure difference and the flow volumes are known. Resistance to flow or blood flow in a single vessel is determined by the radius and length of the blood vessel and by the blood viscosity. Clinically, the most important factor determining resistance in a single vessel is the radius of the vessel lumen. Small changes in lumen radius change or lead to large changes in vascular resistance. Clinically, vasoconstriction can contribute to an increase in resistance, whereas vasodilation will cause a decrease in resistance that may be reflected by a fall in blood pressure. Because vessel length is relatively constant and lumen size is quite variable, length is not as important as the lumen size in determining flow through a single vessel. Because viscosity is largely constant, blood vessel radius is usually the key factor in determining total peripheral resistance. An exception to this rule is when blood or red blood cell volume, measured as hematocrit, is elevated, which is relatively rare. There are some conditions with elevated hematocrits, including a lack of body water, cyanotic congenital heart disease, or polycythemia, and can lead to increased cardiac work as a result of increased vascular resistance. Resistance to flow through a system of vessels, or total resistance, depends not only on characteristics of individual vessels, but also on whether the vessels are arranged in series end to end or parallel side to side, and on the total cross-sectional areas of the system. Vessels arranged in parallel provide less resistance to vessels that are arranged in series. Blood flowing through the distributing arteries, beginning with branches off the aorta and ending at arterioles in the capillary bed, encounters more resistance than blood flowing through the capillary bed itself, where flow is distributed among many short, tiny branches arranged in parallel. The total cross-sectional area of arteriolar systems is greater than that of the arterial system. Yet, the greater number of arterioles arranged in series leads to great resistance to flow in the arteriolar system. In contrast, the capillary system has a large number of vessels arranged in parallel than the arteriolar system, and the total cross-sectional area is much greater. Thus, there is lower resistance overall through the capillary system. The resulting slow velocity of flow in each capillary is optimal capillary tissue exchange. So if we're looking here at an artery, where the small cross-sectional area of high velocity goes through capillaries, where the large cross-sectional area has very low velocity, and our veins and venules has a small cross-sectional area of high velocity. I would even say that's a medium velocity. So, what does that mean for us in terms of velocity? Well, blood velocity or speed is the distance blood travels in a unit of time, usually centimeters per second. Blood velocity is directly related to blood flow, the amount of blood moved per unit of time, and inversely related to the cross-sectional area of the vessel in which the blood is flowing. As blood moves from the aorta to the capillaries, the total cross-sectional area of the vessel increases and velocity decreases. Viscosity. Flow varies inversely with the viscosity. Thick, sticky consistency of the fluid. Thick fluids move more slowly and cause greater resistance to the flow than thin fluids. Just think of honey as compared to water. The viscosity of blood depends on red cell content. The greater the percentage of red cells in the blood, the more viscous the blood. The relationship is expressed as the hematocrit, the ratio of the volume of the more red blood cells to the volume of whole blood. A high hematocrit value reduces flow through the blood vessels, particularly the microcirculation in the arterioles, capillaries, and venules. Laminar versus turbulent flow. Flow through the tubular system can be either laminar or turbulent. Blood flow through the vessels, except where vessels split or branch, is mainly laminar. In laminar flow, concentric layers of molecules move straight ahead. Each concentric layer flows at a different velocity. The cohesive attraction between the fluid and the vessel walls prevent the molecules of blood that are in contact with the wall from moving. The next thin layer of blood is able to slide slowly past the stationary layer, and so on until at the center the blood velocity is greatest. The centermost concentric layer of fluid is not slowed by friction against the vessel wall. Large vessels have room for a large center layer. Therefore, they have less resistance to flow and greater flow and velocity than smaller vessels. So we're taking a couple of pictures here of a parabolic shaped velocity profile and how there is a laminar flow on one side and a turbulent flow on the other. Where flow is obstructed, the vessel turns, or blood flows over rough surfaces. It becomes turbulent, with whirls or eddy currents that produce noise, causing a murmur to be heard on auscultation. Resistance increases with turbulence, which frequently occurs in areas with atherosclerotic plaque. The wall shear stress is the complex interaction between the vessel wall's endothelial layer and blood hemodynamics. Much investigation is on the consequences of lower wall shear stress and the promotion of plaque development distal to the induced stenosis. Classifying wall shear stress and the perivascular changes with inflammation, macrophage activity, medial thinning, and plaque disruption is critical. Vascular compliance. Vascular compliance is the increase in volume a vessel is able to accommodate for a given increase in pressure. Compliance depends on the factors related to the nature of the vessel wall, such as the ratio of the elastic fibers to muscle fibers in the vessel wall. Elastic arteries are more compliant than muscular arteries. The veins are more compliant than either type of artery because they have less smooth muscle. Because they are more compliant, veins serve as storage areas for the circulatory system. Compliance determines a vessel's response to pressure changes. For example, With a very small increase in pressure, a large volume of blood can be accommodated by the venous system. In the less compliant arterial system, where small volumes and higher pressure are normal, small variations in pressure cause little or no change in the volume of blood within the arterial vessels. Stiffness is the opposite of compliance. Several conditions and disorders can increase vascular stiffness, with the most common being aging and arteriosclerosis. Arteriosclerosis increases the rigidity or stiffness of arterial walls, which in turn increases peak arterial pressure at a given volume of blood. Regulation of blood pressure. Your atrial pressure is determined by the cardiac output multiplied by the peripheral resistance. The systolic blood pressure is the highest arterial blood pressure following ventricular contraction or systole. The diastolic blood pressure is the lowest arterial pressure that occurs during ventricular filling or diastole. The mean arterial pressure, which is the average pressure in the arteries throughout the cardiac cycle, depends on the elastic properties of the arterial wall and the mean volume of blood in the arterial system. Your mean arterial pressure can be approximated from the measured values of the systolic and diastolic pressures as follows. Wow, I guess they are doing a map differently these days. So I was always taught that your mean arterial pressure is 1 time your systolic and 2 times your diastolic. You add those numbers together and divide it by 3. I'm not sure what this PD plus 1/3 times your PS minus PD. Your diastolic pressure plus 1/3 times your systolic. Yeah, no, that's. I got a feeling it might be a new way to measure it, but honestly, I will stick with the one that I know, the one that I use, and it is like 97% accurate, if not more. So I'm okay with this. We'll skip to the normal range for MAP is 70 to 110. Wow, 110 is pretty high. The difference between systolic pressure and diastolic pressure, your PS minus PD, is called the pulse pressure, and typically is between 40 to 50 milligrams of mercury. Pulse pressure is directly related to arterial wall stiffness and stroke volume. During a wide range of physiologic conditions, including changes in body position, muscular activity, and circulating blood volume, arterial pressure is regulated within a fairly narrow range to maintain tissue perfusion or blood supply to the capillary beds. The major factors and relationships that regulate arterial pressure are summarized in 3226. The effects of cardiac output. Cardiac output, or minute volume of the heart, can be changed by alterations in heart rate, stroke volume, or the volume of blood ejected during each ventricular contraction, or both. An increase in cardiac output without a decrease in peripheral resistance will cause mean blood pressure and flow rate to increase. The higher arterial pressure increases blood flow through the arterioles. On the other hand, a decrease in cardiac output causes an immediate drop in mean arterial blood pressure and flow table. So it'll give us a little table here of what causes an increase or a decrease. So if your MAP is increased and it increases with peripheral resistance, or if there's a peripheral resistance increase, my MAP increased, but our capillary flow decreases. A decrease in peripheral resistance means there's a decrease in arterial pressure, but a better capillary or an increase in capillary flow. If our heart rate increases, my mean arterial pressure increases, which also improves our capillary flow. A decreased heart rate means a decreased arterial pressure and a decreased capillary flow. If there is an increase in our stroke volume, there is an increase in our mean arterial pressure, which means there is an increase in our capillary flow. Whereas a decreased stroke volume has a decreased MAP pressure, which means a decreased capillary flow. So the only ones that are truly flip-flopped in that sense is our peripheral resistance, or in all reality, our blood pressure. If there's an increase in blood pressure, that means there's an increase in mean arterial pressure, which means, or if there's an increase in our peripheral resistance, which isn't our blood pressure, it increases our blood pressure, but it makes it harder for capillaries to receive the nutrients needed. Whereas if there's a decrease in peripheral resistance, that means there's a decrease in our MAP pressure, which could potentially mean an increase in better capillary flow. The effects of total peripheral resistance and blood volume. Total resistance in the systemic circulation, often referred to as either systemic vascular resistance, or SVR, or total peripheral resistance as TPR, is primarily a function of the diameter of the arterioles. If cardiac output remains constant, arteriolar constriction raises mean arterial pressure by reducing the flow of blood into the capillaries, and arteriolar dilation has the opposite effect. Reflex control of total cardiac output and peripheral resistance includes sympathetic stimulation of the heart arterioles and veins, and 2. Parasympathetic stimulation of the heart. The cardiovascular center in the medulla receives input from the arterial baroreceptor and chemoreceptors throughout the vascular system, and then modifies vagal and sympathetic output to control heart rate and contractility. Plus vascular diameter. Vasoconstriction is regulated by an area of the brainstem that maintains a constant output of norepinephrine from sympathetic fibers in the peripheral arterioles. This tonic activity is essential for maintenance of blood pressure. So, what are your baroreceptors? As discussed earlier, baroreceptors are stretch receptors, located mainly in the aorta and the carotid sinus. They respond to changes in smooth muscle fiber length by altering their rate of discharge, and supply sensory information to the cardiovascular center in the brainstem. When activated or stretched, the baroreceptors decrease cardiac output by lowering heart rate and stroke volume and peripheral resistance, thus lowering our blood pressure. Your arterial chemoreceptors, specialized areas within the medulla oblongata and aortic and carotid arteries, are sensitive to concentrations of arterial oxygen, your PaO2, and arterial carbon dioxide, or PaCO2, and arterial hydrogen ions, RPH, in the blood. Although these chemoreceptors are most important for respiratory control, they also transmit impulses to the medullary cardiovascular centers that regulate blood pressure. A decrease in the arterial oxygen concentration, hypoxemia, an increase in arterial PaCO2 concentration, or to a lesser extent a decrease in arterial blood pH causes a reflexive increase by a dominance of sympathetic impulses in heart rate, stroke volume, and blood pressure. The effects of hormones. Hormones influence blood pressure regulation through their effects on vascular smooth muscle and blood volume. By constricting or dilating arterioles and organs, hormones can increase or decrease the blood flow in response to the body's need, redistribute blood volume during hemorrhage or shock, and regulate heat loss. The key vasoconstrictor hormone includes angiotensin II, vasopressin, an antidiuretic hormone, epinephrine, and norepinephrine. The main vasodilator hormones are the atrial natriuretic hormones. Aldosterone, vasopressin, and natriuretic hormone can influence stroke volume and thus blood pressure by causing fluid retention or loss. A variety of factors, including adipokines and insulin, may be related to the hypertension that occurs with chronic conditions, such as adiposity and diabetes mellitus. But these factors have not been clearly demonstrated to play a role in blood pressure regulation in healthy individuals. Adiposity may increase cardiovascular disease, risk in part through effects on vascular stiffness. Some research has suggested that the risk of cardiovascular disease and hypertension that often co-occurs with diabetes is more closely related to insulin resistance than to insulin levels. Adrenomedullin is a vasodilating peptide present in cardiovascular, pulmonary, renal, and other tissues. Because increases in adrenomedullin levels are associated with heart failure and myocardial infarcts, ADM levels may be useful in or for risk categorization in people with these conditions. So then we also have vasoconstrictor hormones. The vasoconstrictor. So did this talk? Didn't actually specify whether this was vasoconstrictive or dilative. It'll split it up in a moment. I'm jumping ahead. So, vasoconstrictor hormones. Your vasoconstrictor hormones include epinephrine, norepinephrine, angiotensin II, which is part of the renin-angiotensin-aldosterone system, and vasopressin, also known as your antidiuretic hormone. Epinephrine, the catecholamine hormone released from the adrenal medulla, causes vasoconstriction in most vascular beds except the coronary, liver, and skeletal muscle circulation. Norepinephrine mainly acts as a neurotransmitter. However, some also is released from the adrenal medulla. When released into the circulation, it is more potent vasoconstrictor than epinephrine. Under normal circumstances, a vasoconstrictor, angiotensin II, and vasopressin are not thought to have a major role in blood pressure control. Vasopressin and aldosterone, however, affect blood pressure by increasing blood volume through their influence on fluid reabsorption in the kidneys and by stimulating thirst. Vasopressin causes the reabsorption of water from tubular fluid in the distal tubule and collecting duct of the nephron. Aldosterone, the end product of the renin-angiotensin-aldosterone system, stimulates the reabsorption of sodium, chloride, and water from the same locations in the kidneys. So then we have our vasodilator hormones. The natriuretic peptides, or NPs, or hormones including atrial natriuretic peptide, or B-type natriuretic peptide, or C-type natriuretic peptide, and urodilantin, function as both vasodilators and regulators of sodium and water excretion. Natriuresis and diuresis. Mouthful. Increased pressure or diastolic volume in the heart stimulates the release of these peptide hormones. Increased levels of BNP predict increased risk of a poor outcome in heart failure, pulmonary embolism, valvular heart disease, and chronic coronary artery disease. Your BNP is what we've been measuring in our heart failure patients, which is why when it's crazy high, like 22,000 and above, we know that they are not able to maintain their blood pressures. The effects of other mediators. A little far. Several mediators produced by the vascular endothelium have been demonstrated to cause arteriolar vasodilation or vasoconstriction. Examples of vasodilating mediators include nitric oxide and ADM, the endotheliums, and prostacyclins. Nitric oxide is a soluble gas continuously synthesized from the amino acid L-arginine in endothelial cells by the calcium calmodulin dependent enzyme nitric oxide synthase. Nitric oxide has a wide variety of biologic properties that maintain vascular hemostasis, including modulating of vascular dilator tone, regulation of local cell growth, and protection of the vessels from injurious consequences of platelets and cells circulating the blood. So here we can take a look of the importance of nitric oxide in health and disease and lifestyles of associated with nitric oxide. Therefore, nitric oxide plays a crucial role in the normal endothelial function. An emerging list of conditions include those commonly associated as risk factors for atherosclerosis such as hypertension, hypercholesterolemia, smoking, diabetes, and heart failure, are associated with diminished release of nitric oxide into the arterial wall because of the impaired synthesis, and excess of I lost my spot. Impaired synthesis or excessive oxidative degradation. The decreased production of nitric oxide in these pathologic states cause serious problems in endothelial stability. The velocity of blood movement within the arterioles causes shear stress at the vascular endothelial surface, that in turn is the stimulus that causes the endothelial cells to produce these vasodilator substances. The flow-mediated dilation test, or FMD, used to evaluate endothelial function and to predict the risk of cardiovascular disease. A reduction in flow-mediated dilation is predictive of increased risk. ADM, a peptide with strong vasodilatory activity, is present in numerous tissues. It is a member of the calcitonin gene-related peptide family. Its exact role in the adult human cardiovascular function and disease is unclear, but it has been found to have numerous cardiovascular effects, including a role in fetal cardiovascular development and vasodilation. The endothelins are a family of 3 structurally similar peptides, numbered 1 through 3, and 4 receptors produced in cells in the vascular smooth muscle. The endothelium, the kidneys, and other organs, because endothelin binding to the type A receptor causes vasodilation, and natriuresis, whereas binding to type B receptor causes the opposite response, vasoconstriction, plus sodium and water retention. The understanding of the physiologic and pathologic roles has been complex. Inhibitors to endothelin 1 have been approved for the treatment of pulmonary hypertension. Prostacyclin is a vasodilator that is produced by the action of cyclooxygenases, or COX-1 and 2, on arachidonic acid. It also has the additional property of opposing clot formation and antithrombotic, decreasing platelet activity and inhibiting the release of growth factors from macrophages and endothelial cells. Non-steroidal anti-inflammatory drugs, or NSAIDs, that inhibit the cyclooxygenases have been associated with cardiovascular disease risk in healthy people and those with a known cardiovascular disease. Natokinases, or NK, activates multiple
fibrinolytic and antithrombotic pathways simultaneously, either directly or indirectly. So, in summary, the nattokinase intake could be an exceptional fibrinolytic anticoagulant agent to reduce the risk of thrombosis and in humans. So there is a traditional food in soybeans within fermented Bacillus subtilis that has strong fibrinolytic properties and consumed for more than 1,000 years, especially in the region of Japan. With NK serum activity between 2 and 24 hours in healthy subjects and an increased fibrinolysis and anticoagulant indicators between 2 and 8 hours, other data from animal and human studies have evaluated the action of nattokinase. Using a clot lysis assay in vitro, the cleavage of cross-linked fibrin was 6 times more efficient than that by plasmin. And in rats, was 4 times more effective in dissolving a thrombus. So, eat your soybeans, apparently. Known to take away thrombi. Hey, who knew? Just a 1, 2, 3. So, that leads us to venous pressure. The main determinants of venous blood pressure are the volume of fluid within the veins and the compliance or distensibility of the vessel walls. Typically, the venous system accommodates approximately 66% of the total blood volume, with venous pressure averaging less than 10 milligrams of or mm of mercury. The systemic arteries accommodate about 11% of the total blood volume, with an average arterial pressure of about 100. The remainder of the blood volume is within the heart, capillaries, and pulmonary circulation. The sympathetic nervous system controls compliance. The walls of the veins are highly innervated by sympathetic fibers that control venous smooth muscle. Sympathetic innervation to the veins result in an increase in smooth muscle tone rather than vasoconstriction, which occurs in arteries. This increased smooth muscle tone stiffens the walls of the veins, reducing distensibility and increasing venous blood pressure, thus forcing more blood through the veins and into the right heart. Two other mechanisms that increase venous pressure and venous return to the heart are the skeletal muscle pump and the respiratory pump. During skeletal muscle contraction, the veins within the muscles are partially compressed, causing a decrease in venous capacity and increased return to the heart. The respiratory pump acts during the inspiration, when the veins of the abdomen are partially compressed by the downward movement of the diaphragm. Increasing abdominal pressure moves blood towards the heart. The regulation of the coronary circulation. Coronary blood flow is directly proportional to the perfusion pressure and inversely proportional to the vascular resistance of the coronary bed. Coronary perfusion pressure is the difference between pressure in the aorta and the pressure in the coronary vessel. Thus, aortic pressure is the driving pressure that propels the perfusion of myocardial vessels. Vasodilation and vasoconstriction maintain coronary blood flow despite stresses imposed by the constant contraction and relaxation of the heart muscle, and despite shifts within a physiologic range of coronary perfusion pressure. Several unique anatomic factors influence coronary blood flow because of their location. The aortic valve cusps can obstruct coronary blood flow by pushing against the opening of the coronary arteries during systole. Also during systole, the coronary arteries are compressed by ventricular contraction. The resulting systolic compressive effect is particularly evident in the subendocardial layers of the left ventricular wall and can greatly increase resistance to the coronary blood flow. Therefore, Most coronary blood flow in the left ventricle occurs during diastole, during the period of systolic compression when flow is slowed or stopped. Oxygen is supplied by myoglobin, a protein in the heart muscle that binds oxygen during the contraction and supplies oxygen to the myocardium. Autoregulation. So autoregulation or automatic self-regulation enables organs to regulate blood flow by altering the resistance diameter in their arterioles. Autoregulation in the coronary circulation maintains the blood flow at a nearly constant rate at perfusion pressures, mean arterial pressure between 60 to 140, and other influencing factors are held constant. Thus, autoregulation helps to ensure constant coronary blood flow despite shifts in the perfusion pressure within the stated range. Given that blood flow is directly related to pressure and inversely related to resistance, for flow to stay constant as pressure decreases, resistance also has to decrease. Thus, the mechanisms underlying autoregulation must relate to control of smooth muscle contraction in the arteriolar wall. Although the exact mechanism underlying autoregulation are not known, research has indicated that factors influencing calcium release with the myocardium are involved and perhaps also the accumulation of vasodilatory products of metabolism such as adenosine. The lymphatic system. The lymphatic system is a one-way network of lymphatic vessels and lymph nodes that is important for fluid balance, immune function, and transport of lipids, hormones, and cytokines. Every day, about 3 liters of fluid filters out of the venous capillaries in body tissues and is not reabsorbed. This fluid becomes the lymph that is carried by the lymphatic vessels to the chest where it enters the venous circulation. The lymphatic vessels run in the same sheaths with the arteries and veins. Lymph nodes and lymphoid tissues are described in Chapter 7 and 28. In the pumpless system, a series of valves ensures one-way flow of the excess interstitial fluid towards the heart. The lymphatic capillaries are closed at the distal ends. So just a show of all the lymph nodes and major locations of our lymphatic system. Again, an anatomy course. Lymph consists primarily of water and small amounts of dissolved proteins, mostly albumin, which are too large to be reabsorbed into the less permeable blood capillaries. Lymph also carries 2 types of cells, lymphocytes and antigen-presenting cells. The antigen-presenting cells are carried to the next lymph node in the system where lymphocyte traffic between lymph nodes. Once within the lymphatic system, lymph travels through the lymphatic venules and veins that drain into one of the 2 large ducts in the thorax, the right lymphatic duct and the thoracic duct. The right lymphatic duct drains lymph from the right arm and the right side of the head and thorax, whereas the larger thoracic duct receives lymph from the rest of the body. The right lymphatic duct and the thoracic duct drain lymph into the right and left subclavian veins, respectively. Lymphatic veins are thin-walled, like the veins of the cardiovascular system. In the larger lymphatic veins, endothelial flaps form valves similar to those in the blood-carrying veins. The valves permit lymph to flow in only one direction because lymphatic vessels are compressed intermittently by contraction of skeletal muscles. Pulsatile expansion of an artery in the same sheath, and contraction of the smooth muscle in the walls of the lymphatic vessel. As lymph is transported towards the heart, it is filtered through thousands of bean-shaped lymph nodes clustered along the lymphatic vessel. Lymph enters the nodes through several afferent lymphatic vessels, filters through the sinuses in the nodes, and leaves by the way of efferent lymphatic vessels. Lymph flows slowly through the node, which facilitates the phagocytosis of foreign substances within the node by antigen-presenting cells and the entry of mature but naive B and T lymphocytes, which then circulate through the body, moving from one lymph node to the next while waiting for a chance encounter with the antigen to which they are programmed to respond. That's phagocytosis in Chapter 7. So what kind of tests of cardiovascular function do we do? The assessment of individuals with suspected cardiovascular disorders begin with a thorough history for determination of risk factors and symptoms. A careful physical exam looking for evidence of tissue ischemia, pulmonary congestion, and cardiac dysfunction is next. Blood samples are taken and sent for a variety of tests. For many individuals, these basic steps will be complemented with methods that measure heart and vascular function with greater specificity. Cardiac function can be evaluated using indicators calculated from pressures and flow rates in the heart and vessels. Table 32.6 defines the indicators most often used in the clinical setting. The normal values for several testing methods are different for men and women. This textbook's inside back cover includes normal blood values for common lab tests. Sure. So we got heart rate, cardiac output, cardiac index, stroke volume index, oxygen, stroke work index, systemic mean arterial pressure, pulmonary vascular resistance, and systemic vascular resistance. Okay. So cardiac and coronary artery evaluation. Many sophisticated tests are used to evaluate and diagnose cardiac or coronary artery disease. And new ones are being tested each year. Some of the more commonly used modalities include chest x-rays, electrocardiography, echocardiography, stress testing, computed tomography, and magnetic resonance imaging, technetium scanning, electrophysiology studies, and catheterization with angiography. Yeah. Chest x-rays allow us to examine the size and contour of the heart and related structure. The evidence of chamber enlargement, pericardial disease, pulmonary edema, valvular calcification, ventricular hypertrophy, and pathology of the great vessel may be visualized. A chest x-ray also has been useful to assess for appropriate placement for invasive cardiac conduction devices and for complications caused by these devices. A pneumothorax or hemothorax. A chest x-ray examination is a routine part of cardiac exams. Most commonly obtained views are the posterior and lateral, with the individual standing upright and the lungs fully expanded. In those individuals confined to bed, an anterior-posterior view may be obtained, but is usually of lesser quality. Your electrocardiography, or EKG, typically a 12-lead electrocardiogram, gives information about heart rate and rhythm, the effects of activity of daily life, exercise, electrolytes, drugs, or disease on electrical activity in the heart, and the electrical orientation of the cardiac muscle. An EKG provides no direct information about the contractile state or mechanical performance of the heart.
Serial 12-lead EKGs are the primary importance in establishing the presence of myocardial ischemia and infarction or conduction defects and dysrhythmias. This examination has become part of the routine hospital pre-admission or admission assessment, even when the admitting diagnosis is not cardiac in nature, because it establishes a baseline information about the electrical function of the heart. Also, recent EKGs can be compared with EKGs obtained from the same individual in the past, so that changes in the EKG over time assist in determining the cause, amount, or nature of change in cardiac anatomy and physiology. Ambulatory electrocardiographic or Holter monitors are used to evaluate rhythm changes that may occur during the person's during activities of daily living. Cell phone technology also is rapidly advancing to enable EKG recording and relaying that to healthcare providers. I mean, let's face it, everyone's walking around with some type of smartwatch at this point that can tell you if your heart jumps into AFib. So, very true. Your echocardiography or echocardiography is most effective and widely used non-invasive modality for evaluating the structures of the heart. The ultrasound beams reflected by cardiovascular structures produces shapes that can be visualized and allowing for recognition of altered cardiac anatomy. It is used to evaluate the suspected coronary artery disease, heart failure, valvular disease, infective endocarditis, cardiomyopathies, pericardial disease, prosthetic valve function, congenital heart disease, and aortic diseases. Through the use of M-mode, 2 or 3-dimensional techniques with Doppler and color flow imaging, accurate assessment of cardiac output, ejection fraction, and valvular function can be obtained. Advances in technology now allow both intracardiac and transesophageal echocardiography for evaluation of heart anatomy, although anesthesia is required for the transesophageal technique. Your TEE. Exercise or stress testing. Cardiac activity during exercise is examined during a stress test, when an intervention is used to increase myocardial work. Stress testing elicits signs and symptoms of heart disease and coronary artery disease that may not appear at rest. Echocardiography or continuous 12-lead EKGs and blood pressure measurements are obtained before, during, and after the study. Cardiac stress from the exercise is usually induced by having the individual walk on a treadmill. Other, less frequently used forms of exercise include static exercise, hand ergometry, and chemical stress. Stair climbing, the Stairmaster double two-step, arm ergometry, and bicycle ergometry. The individual exercises until the maximal heart rate for gender and age is reached, or until other subjective or objective indicators of cardiac dysfunction or distress appear. Subjective indicators include chest pain, extreme fatigue, extreme dyspnea, leg pain, or the individual's request to stop the test. Objective criteria are ST segment elevation or depression, SA node or atrial dysrhythmias, AV node dysrhythmias, ventricular dysrhythmias, elevated or decreased blood pressure, signs of cerebral hypoxia, and signs of circulatory insufficiency. One limitation of this test is that it cannot be used in persons whose capacity for exercise is limited. Stress testing also may be used to evaluate either fitness for non-cardiac surgery or progressive and recovery after myocardial infarct or cardiac surgery. Graded exercise in individuals with low to moderate risk chest pain evaluated in the emergency department can be used as a prognostic indicator of adverse cardiac events. When a differential diagnosis for chest pain has been difficult to determine, stress testing may help distinguish coronary artery insufficiency from other causes of pain. The risks associated with stress testing include dysrhythmias, myocardial infarct, and death. The risk is greater when the test is performed soon after an acute ischemic event. Stress testing with EKG monitoring may not be sensitive enough to detect and localize areas of a myocardium at risk for ischemia and infarct. Currently, most stress testing includes the injection of a radiotracer that is absorbed by active heart cells. When the heart is scanned during and after the stress testing, areas where radiotracer is not taken up by the ischemic cells can be seen, and those locations indicate areas of myocardial damage. Then we got our CT scans, or single photon emission computed tomography, is typically used to evaluate individuals for coronary artery disease and myocardial ischemia during stress testing. Oh, this is a different test. A single photon emission, I guess, is the primary portion of that. A radiotracer is injected intravenously and is absorbed and retained for a while by healthy myocytes. Photons are emitted from the radiotracer in the myocardium in proportion to perfusion of the tissue. A gamma camera visualizes the photons, and views are taken at 360 degrees via CT, which digitalizes the information and provides a three-dimensional view of the myocardial perfusion. Data about where the myocardium absorbs the tracer normally, slowly, or not at all, can be correlated with existing myocardial disease and can help quantify ischemic risk. A new development in high-speed SPECT has the advantage of taking less time and thereby requiring less radiotracer, which decreases radiation exposure for the person being examined. Then we have, I guess, our classic CT and MRI, which shows us our pictures of the heart. Are used to evaluate cardiac anatomy and physiology. A new technique, including EKG gathering, electron beam CT, and spiral CT, have improved the ability of tomography to visualize cardiac structures. The high resolution of CT can provide information about calcification of coronary vessels and cardiac valves. Information about coronary artery calcification is being used to improve risk classification for CAD. It also is a tool for evaluating large vessel disease. Concerns and debate continue, however, about the radiation risk and use of variable protocols. The International Commission on Radiological Protection recently released a report on radiological protection in cardiology, but it doesn't say what it said. Classic. MRI is based on the principle that the frequency of energy given up by the nucleus is exactly proportional to the surrounding magnetic field. The anatomy and physiology of the great blood vessels and myocardium are depicted in 3 dimensions with excellent resolution. Ventricular function can be evaluated using indexes of ventricular function, such as ejection fraction. Rapidly moving sequence MRIs can determine regional wall motion and myocardial deformation. Flow direction and velocity can also be quantitatively determined. Stress testing also can be done with MRI using a drug dobutamine to increase the cardiac workload instead of exercise. And then the technetium scanning. Radiopharmaceutical label with technetium preparations such as sustamib, teboraxime, and tetrophosmin are used to image the coronary artery and myocardium. The technetium pyrophosphate is injected IV into the resting individual during a hotspot imaging examination. 2 hours after injection, the distribution pattern of the radioactive solution is recorded by a nuclear scan. During the 2-hour delay, the injected material will have been taken up by the infarcted areas of the myocardium. particularly 1 to 3 days after the onset of symptoms. This type of scanning also is done with stress testing using exercise and dobutamine. Study results are not definitive during the 12 hours after an infarct. So, technetium scanning is used when 1. There is a conflicting history of myocardial infarct, or 2. There are equivocal EKG abnormalities, or 3. An individual's cardiac enzymes have been elevated because of surgery or trauma. Ongoing research is determining any risk associated with radioactive substances. Electrophysiology studies. In-depth evaluation of electrical conduction within the heart can provide important information about the nature and causes of dysrhythmias, such as atrial and ventricular tachycardias and heart block. This evaluation is often referred to as electrophysiologic mapping of the myocardium. There are many types of electrophysiology studies that are specific to certain conduction disorders, but they have the common goal of documenting abnormal conduction pathways. Furthermore, the techniques used may also allow for ablation of unwanted pathways, or the appropriate placement of pacemakers and implantable defibrillators. Mapping can include the use of echocardiography and CT scanning. One example of electrophysiology study is AV bundle electrocardiography. 2 electrode-tipped catheters are inserted percutaneously into the femoral vein, floated up the inferior vena cava, and positioned in or near the right atrium during AV bundle His bundle electrocardiography. AV bundle electrocardiography can detect secondary sites of impulse generation, or ectopic foci, as well as accessory pathways of conduction. Other conduction defects and the effects of drugs on conduction also can be illuminated. Risks related to this procedure can be grave and include dysrhythmias, death, vessel or heart perforation, clot or plaque embolization, and kidney failure, due to, most likely, the dyes used. Cardiac catheterization and angiography. One or both sides of the heart can be examined using cardiac catheterization. This invasive procedure requires the use of fluoroscopy and strict sterile technique and takes place in a specially equipped catheterization lab. Local anesthetic is administered and a catheter is introduced percutaneously into the vasculature and passed caudally into the atrium and ventricle. For a right heart catheterization, the catheter is placed in either the jugular, subclavian, brachial, or femoral vein. The femoral artery is commonly used for left heart study. Once the catheter has been guided into the heart chambers, pressures are recorded, blood samples are obtained to examine oxygen content, and a contrast medium is injected to visualize chamber function and valve patency. Cardiac catheterization provides a means to visualize the chambers of the heart continuously, although for a short time. A great deal of information can be obtained about heart structure and function. Pressure in each chamber and across heart valves can be precisely measured, along with timing of events in the cardiac cycle. Of particular value is the ability to compare the oxygen content of blood in each heart chamber. Risks for this procedure that have decreased over time include the development of dysrhythmias. Death can occur secondary to cardiac arrest after ventricular fibrillation. Fluoroscopy visualizes the coronary artery and left heart structures using contrast dye called coronary angiography or arteriography. Like cardiac catheterization, this study takes place in a catheterized lab using local anesthesia and a sterile field. A catheter is threaded into the left ventricle through the femoral artery. A ventriculogram generally is performed first. Contrast dye is injected into the apex of the ventricle, and the next few cardiac cycles are visualized and filmed. Like cardiac catheterization, coronary Angiography is used to gain information about the structure and function of the ventricles and related valves. After the ventriculogram, catheters are introduced individually into the ostia of the coronary arteries. When the catheter is in position, a small volume of contrast dye is mechanically and rapidly injected into the artery, and the results are visualized and filmed. Dye injection is repeated with the individual tilted at various angles to afford views of the artery other than the anteroposterior view. The risk of for coronary angiograms is similar to those of cardiac catheterization, with the exception as the blood supply to the cardiac muscle is briefly interrupted when dye is introduced into the coronary arteries. Angina, chest pain, caused by ischemia, is much more common. Coronary artery spasms also can occur. Interrupted blood flow causes decreased heart rate, as well as tachydysrhythmias, hypotension, and ST segment depression. Systemic vascular evaluation. The systemic vascular system can be studied by a variety of techniques in order to evaluate for adequate flow rates, vascular obstruction, and structural defects. These techniques include Doppler ultrasonography, CT, MRI, venography, and arteriography. Arterial pressure pulse waveform analysis. Pulsation described by the flow of blood through an artery during the cardiac cycle can be drawn as a waveform, plotting pressure against time. The waveform can be obtained non-invasively by placing a transducer on the skin over the carotid artery, while the individual's head is turned slightly away from the transducer. The amplitude and shape of arterial waveform can provide information about the elasticity of the arterial wall, or its inverse, the stiffness of the wall. Your Doppler ultrasonography studies. A Doppler study is done using a microphone that amplifies and records the sound made by blood flowing in peripheral vessels. The Doppler microphone is placed over the vessel to be studied, and sounds related to the obstruction to flow, vessel wall mobility, and heart murmurs are transmitted through the lubricating gel to the microphone. The audio findings can be digitalized into visual findings that can be analyzed for flow velocity and volume. These studies are useful in the evaluation for abnormalities of venous flow, deep venous thrombosis, and arterial flow, or emboli. Ultrasound also is used to calculate the thickness of arterial walls, yielding a reading called intimomedial thickness. Carotid intimomedial thickness is used to assess for atherosclerosis. Many people are familiar with ultrasound measurements because they are commonly used to assess fetal growth and development. CT and MRI are used to evaluate the systemic circulation, providing information about the structure of the great vessels. Either can be used to evaluate for aneurysms and dissections of the thoracic or abdominal aorta. CT also is used to assess for vessel calcification and provide some insight into the risk for stroke and myocardial infarct through evaluation of the carotid and coronary vessel. Venography and arteriography are radiopaque dye can be injected through intravenous and intraarterial catheters to allow for visualization of the internal structure, diameter, and patency of veins and arteries. Venography is performed primarily in the lower extremity to assess for the presence of thrombi in the large veins of the leg. Arteriography can be used in almost any vascular system, including the great vessel and the pulmonary, coronary, cerebral, mesenteric, renal, hepatic, and peripheral arteries. Risks include rupture, dissection, thrombosis, embolization, or organ infarction involving the arterial system being studied. So definitely a risk to it. That leaves us with aging in the cardiovascular system. Cardiovascular disease is the most common cause of morbidity and mortality in older adults in Western society and in much of the rest of the world. In addition to age is a key driver of cardiovascular risk, which explains why it is primary cause of death in persons older than the age of 65. The most common cardiovascular disease condition is hypertension, followed by coronary atherosclerosis, for which hypertension is a risk factor. It is challenging to determine the normal physiological changes in cardiac function with aging because many pathologic changes aren't usually present and physical fitness is variable in older people as well. Studies of the effect of age on cardiovascular function must be rigorous in their distinction between persons who are free of disease and those who have disease that may be evident only during testing. There is a wide range in the older population for nearly every cardiovascular variable. These variations are related to an increase in the prevalence of hypertension and coronary disease with advancing age. The growth in the segment of the population older than 65 and major age-associated changes in lifestyle. The most relevant age-associated physiologic change in cardiovascular performance includes myocardial and blood vessel stiffening. Changes in neurogenic control over vascular tone, increased occurrence of atrial fibrillation, and loss of exercise capacity, plus left ventricular hypertrophy and fibrosis. These changes pose considerable consequences, with increased demand for flow, with change in posture, or with disease. Arterial stiffening occurs with aging, even in the absence of clinical hypertension. It can, however, be an important contributor to systolic hypertension and its associated risk for cardiovascular events, dementia, and death. These changes result from alterations within the vascular media, including age-associated changes in cross-linking of collagen, an increase in the amount of collagen, deposition of calcium, and changes in nature of elastin, the extracellular matrix, inflammatory molecules, endothelial cell function, and reactive oxygen species. The increased arterial stiffening may not be related strictly to an age-associated change in vascular structure, but may be caused by changes in baroreceptor activity. Baroreceptor activity may decrease with age, slowing physiologic adjustments to changes in blood pressure and posture. In persons older than the age of 60, pulse pressure, which is directly influenced by arterial stiffness, is a better predictor of cardiovascular disease than either diastolic or systolic blood pressure. Left ventricular hypertrophy and fibrosis also are common in the aging population, even in the absence of high blood pressure. As the arterial system becomes stiffer, the ventricles must work harder to pump blood through the body, thus contributing to hypertrophy. Fibrosis, calcification, and increase in stiffness also impact valvular function, particularly the function of the atrioventricular valves. These changes make valvular disease a greater risk for the elderly, along with an increased risk of heart failure related to the left ventricular hypertrophy and stiffness. The advent of genomic medicine and a deeper exploration of molecular changes with aging continue to enhance understanding of the myriad changes in people's bodies as they age. The ongoing hope is that as understanding of the causative factor related to cardiovascular decline with aging improves, therapeutics that arrest or slow these changes may develop. Stress testing is used to uncover functional capacity losses that are not apparent at rest. In contrast to the subtle effects on resting cardiac tests, more dramatic changes occur during exercise. Table 32.3 summarizes age-associated changes at rest and during exercise. Overall, Long-term exercise conditioning in older individuals increases aerobic capacity and decreases arterial stiffness and left ventricular function so that cardiovascular diseases may be prevented or delayed in older adults. Although the risks and benefits of pharmacologic and invasive strategies must always be assessed carefully, many older adults can live longer and healthier lives if appropriate preventative and treatment regimens are offered, even quite late in life. So that concludes our chapter, and we will jump into chapter 33 next. So, for the time being, I think we will call it a break here, and we'll continue on with the next stream. I thank you all for watching, for being part of the stream, for being willing to learn more about your cardiovascular health, and we shall see you next time. Take care and goodbye.